Parfait. Okay. So, okay, let's start. Today we have diabetes and thyroid disorder or dysfunction, thyroid gland dysfunction. When we have a question, you will have to answer in the conversation room or the chat room that we have here. Okay. Next time, inshallah, هنكون حلينا we will solve the issue of this of the pool. But for now, okay, we have to answer here in the conversation on the chat room. Okay, my friends. Okay, so let's start. Let's start by our first question today, and we will discuss everything later. Uh, okay, this is a single question. It's not a case. Okay, so for question number one says, which test is usually used for thyroid glands function screening? When we do screening, what test we are doing? Thyroid stimulating hormone or free triiodothyronine, which is the T3, or free thyroxine, or anti-TPO antibodies, antithyroid peroxidase antibodies. Okay. Okay. I can see here that most of the answers are going to number A. Okay. While we have Rashmi, she had the courage and answer number B. She went for B. Yes. Yes, Rashmi. Okay. Are we done? No more answers? Faid answered. Rima, Noura, Noha, Maryam, Shaima. Okay, Armia. Where is Armia and his... فين الناس التانية؟ بقية الناس فين؟
Yes, sir, I will answer now.
Answer يا يونس سير. What's your answer?
Yes, I will
You
write
were
it.
searching for the answer or what?
No, no, no.
Okay.
It's
It's A. Okay, perfect. So here, okay. Uh, okay, and okay, perfect. So most of the answers went to number A, while Rashmi went to number B. Why do you believe number B is correct, Rashmi? You are the only one that believes that who believes that number B would be correct. For what reason?
Uh,
Do you have any rationale?
uh, hmm, there is no specific reason. Actually, I thought I have read somewhere.
You read it somewhere?
Yeah.
Okay. Okay. For screening, only for we are talking here about screening. Okay. For screening, we only do the TSH. Okay. If there is
Okay.
abnormalities or any symptoms or any suspicious about the thyroid gland dysfunction, then we can go for further tests like the T4 and T3, and even we can do for the antibodies of TPO, antibodies for thyroid peroxidase. Okay, but
Okay.
when it comes to screening only, we're not doing the whole profile or the whole panel, thyroid panel. We are only doing the TSH. Okay.
Okay.
Yes. So it's only TSH. Correct.
Thank you.
Okay. Good job to all of you. Please keep the momentum. Okay. We have second question here. Which of the following is not a determinant to treat patient with subclinical hypothyroidism? Lipid profile, atrial fibrillation, pregnancy, cold intolerance. Which of the following is not a determinant to treat patient with subclinical hypothyroidism? Do you understand the question? Hmm. Okay. Okay, I got only 3 answers. 4 answers, please. Yes. Faid, Armia, Rana, Noha, Iz, Rima, Rashmi. Okay. Who's else? Who's else? ديفيد فين يا ديفيد؟ حارمنا ليه من صوتك؟ ليا. Okay. Okay. I need 2 or 3 more answers and then we can go. Give me 2 or 3 more answers, please. Yes, Ziad saying A. Rima is changing her answer to B. Atrial fibrillation. Interesting. Okay, perfect. So we are done now. Okay, end. Okay, I typed in. Okay, perfect. So actually, we got some interesting answers here. D, D, A, C, D, C, A. Okay, most of the answers are D and A. Okay, we have only Salam who's saying B, Summer B, Ez B, and Hiba B. Okay, so what is the meaning of this question? What about what we are asking about actually? Have you understood the question? What does it mean?
Yeah, you ask about the subclinical hypothyroidism. Subclinical hypothyroidism, in general, in the hypothyroidism, it is increase in the TSH4.
No, I
And it
don't
is,
need any definition. I
I
would
know.
like to just hit the question, my friend. Hit the
Okay,
question.
okay. The subclinical hypothyroidism, the TSH is normal, and the T3 and the T4 is decreased.
I'm not talking about that here. What the question is? The question talking about that?
Not determined to treat in the subclinical hypothyroidism. Okay.
When to exactly? Here's Ziad saying when to treat subclinical hypothyroidism, except yes, this is the correct meaning. Okay, it's not a determinant. When we treat the hypothyroidism, generally speaking, if subclinical hypothyroidism, there is no symptoms with the subclinical hypothyroidism, which is almost the case. Most of the cases are like that. So no need to treat it. We only monitor it. Okay, we only monitor it from time to time, from about 3 or 6 months, as I don't know. But we have, in some cases, we have to treat it. Like what? If there is high hypercholesteremia or any sign of dyslipidemia, in this case, you have to treat subclinical hypothyroidism because the case will be deteriorated. Okay. If there is a lady in breast giving age, yes, and willing to get pregnant, in this case, you have to treat it. If there is cold intolerance, what does it mean, cold intolerance?
Symptoms of
Yes,
hypothyroidism.
yes. So there is a symptom, correct? In this case, you have to treat it. Atrial fibrillation, this is relevant.
This is a hyperthyroidism, could be.
Exactly. If there is subclinical hyperthyroidism, in this case, for atrial fibrillation, yes, we can treat it. Okay. So the correct answer, as Salam and Iz and Rima changed her mind, and Hiba as well. Yes, correct. Bravo to all of you. Perfect. So B is the right answer here. Okay. Let's proceed. Which is correct about subclinical hyperthyroidism? Which is correct about subclinical hyperthyroidism? TSH is suppressed while thyroid hormone is normal. TSH is suppressed while thyroid hormone is elevated. Subclinical hyperthyroidism is generally uncommon and usually left untreated unless the patient is at risk of atrial fibrillation. Number D, B, and C is correct. Yes. What do you think? Okay, I got two answers. Three answer. Four answers. 5, 6, 7. Yes. 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 Yalla go. 8, 9, 10. I think we have 10 answers now. 11. Okay. Give me more two answers, please. More two answers. B. Yes. Okay. Can we have one more answer? 5. Correct. Okay. Okay, my friends. And can you see the screen? All your answers are wrong. All your answers are wrong. Why? Why? Can you tell? Can you tell? Can anybody tell me? Yes, it's A. Yes, it's A. Yes. Of course it's A. Okay. Why? Okay. So why A is correct. Okay. Why A is correct. What is the definition of subclinical hyperthyroidism? Yeah, Armia. You were defining a few seconds ago the subclinical hypothyroidism, correct?
Yes, subclinical hypothyroidism. It is the TSH. It is normal while the thyroid gland is high. The thyroid normal is high.
Excuse me, just repeat it.
Okay, again, subclinical hypothyroidism. The TSH value is normal,
Yes.
while the thyroid hormone is elevated.
No, it's not like this.
You inverse it, my friend. You make it the opposite. The TSH is elevated while the thyroid hormone is normal. This is a subclinical hypothyroidism. That's why it's subclinical, okay? Because the thyroid hormone is normal. There is no symptoms. What makes the symptoms of the thyroid gland dysfunction? Is it the TSH or the thyroid hormone? It is the thyroid hormone itself who controls the body system in general. Okay, it's the thyroid hormone. It's not TSH. We use TSH like an indication. Okay, so that's why it's subclinical. The same concept applies to the subclinical hyperthyroidism. TSH is suppressed while thyroid hormone is normal. If you have TSH suppressed, this means what? You have hyperthyroidism. Okay, so normally the thyroid hormone should be elevated, but here it's normal, which
Doctor, in all cases, TSH still is the mainstay of diagnosing. Like, if it is increased, there is hypothyroidism. If it is decreased, it is hyperthyroidism. And if any of the hormones are normal, it's considered hypo or hyper depending on the TSH, right?
No, it's not like that. Would you repeat that,
So I'm saying if the TSH is decreased, this means it's hyperthyroidism.
Yes, correct.
And if it is increased, it's hypothyroidism. and regardless of the like free T4 and T3. Free T4 and T3 goes on the opposite way of the TSH. This means not a subclinical. This means the normal diagnosis. If it is
Yes,
subclinical, it's within the normal range.
yes,
For
yes.
both.
If they are going, yes, if they're going on the opposite directions, like TSH is up and if F3 or F4, yeah, T3 or T4 are down, this means hypothyroidism, as you said. It's regular or clinical hypothyroidism.
Yeah.
Okay, but here we have subclinical. Subclinical means there is no symptoms. The thyroid hormone is normal, it's going well. The body functions are going as normal. Okay, while there is a problem, the TSH is not a good indication here. It indicates here that there is a hyperthyroidism.
Doctor,
Okay.
does the opposite happen? Like the T4 and T3 are, let's say, elevated or decreased, and the TSH is within range?
If TSH within, you mean if TSH is normal while T4 are elevated or down?
Yeah.
I think maybe no. I don't think. I don't know. Actually, no. No. But here, if even in secondary hyperthyroidism or thyroid dysfunction, or if there is a problem with the hypothalamus or pituitary gland, I think the TSH should be affected as well. Okay, TSH should be affected. But you are saying that if TSH is normal,
Yes.
I don't think so. I don't know, actually.
Okay.
As much
Okay.
as I know, no.
Okay. Thank
Okay.
you.
Okay, perfect. So the right definition, guys, is number A. TSH is suppressed, thyroid hormone is normal. This is correct. Okay, so by extension, we can say that B is wrong. Here, subclinical hyperthyroidism is generally, it's common. It's common and usually left untreated, yes, unless the patient is at risk of atrial fibrillation, and we have other conditions as well. Okay, we have three other conditions. If there is osteoporosis, or if the patient is elderly, okay, and that's it. Okay, so it's not only atrial fibrillation, we have three or four other cases. Elderly patients, atrial fibrillation, osteoporosis, and we have one more. I cannot remember actually.
Pregnancy?
No, it's not pregnancy. No. Okay, can you please repeat the subclinical hypothyroidism? Okay, subclinical means if you have ever seen subclinical means that the thyroid hormone are normal. Okay, either it's a subclinical hyperthyroidism or hypothyroidism. So we have thyroid hormones are normal. Okay, if you have hypothyroidism, this means that you have high TSH. If you have hyperthyroidism, it means that you have low TSH. Okay, that's it. Okay, so the right answer here is A, guys. It's not B, it's not C, nor D. Okay, let's proceed. ركزوا يا شباب. انتوا بدأتوا بداية قوية وبعد كده ايه الأداء بدأ. عشان كده I told you keep the momentum, right? Let's proceed. Which of the following minerals or supplements may have benefit in thyroid gland dysfunction? If it's the selenium, iodine, biotin, or zinc. Okay, we have one answer here. Number A from Miriam. Parfait. Summer is saying as well A. Sarah A. Rashmi A. Siba C. Leah A. Sarah's asking, how about iodine? I don't know. I have no idea. You have to choose. What's your answer? Thyroid base LB. I don't know. Hmm. B. Siba B. Okay, choose A. Sarah A. 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 B. B, C. Okay. And okay. You can see that some of you, about 4 or 5, Miriam, Summer, Sarah, Rashmi, Leah, okay, answered A, while the rest answered B. The correct answer is A, selenium. Okay, selenium could have a benefit in thyroid dysfunction, correct? Iodine. Iodine is important to keep the normal thyroid gland functions. Okay, iodine is important to keep the function of the thyroid gland. Yes, but here we are talking about if you have a dysfunction in the thyroid gland. Okay, which mineral we use? Can we use biotin, zinc, iodine, or selenium? Selenium. It's selenium. We use selenium usually. Okay, and it has in what case actually we use selenium? Is it in hypo or hyperthyroidism? We use selenium. Yes, correct. No, we use it in hyper, my friends. In the hyperthyroidism. يا ديفيد انت اتاكد من اجاباتك يا ديفيد الاول ما تتعبناش. Okay, hyperthyroidism. It's not hyper. Okay, we use it in hyperthyroidism and we will address that later. Okay?
Doctor, please.
Yes.
In this case, for example, in the goiter, which is the thyroid enlargement, the most relevant causes from the goiter, it is the iodine deficiency. And in some cases, we treat the patients with iodine radioactive. So this is the first time for me, actually, I listened for the selenium. I know it is the selenium.
No, you will have it. Okay, let me answer you, Armia. Yes, you will have it in the CTC.
Can I complete something? Can I complete something, please?
Complete,
okay.
Yeah.
Okay. Which I read that the selenium used to the prevention of worsening of the mild graves or pathopathy. الناس اللي عندها مشكله في الاوربت، انا بستعمل، وده موجوده في التي سي، انا بستعمل السليم، بس الايودين انا بستعمله في صوره اللوجال سوليوشن عشان اعالج الثيرويد هرمون برودكشن. ده اللي انا اعرفه.
Yes. There you go. And you have it. Can you see the screen? Selenium is required for deiodinase activity. The enzyme is 0 or whatever. It has an important effect on immune function. The effect of selenium deficiency in normal thyroid function are not well described. However, selenium deficiency has been shown to exacerbate both autoimmune thyroid disease and endemic latinism. Selenium supplementation reduces antithyroid hormone. Okay, and etc. And you have here symptom normalization of TSH. Yes, this is yes, hypothyroid individual. And you have another note on the selenium in the CTC. It's written that you can use it as well, as you said, in the goiter and to prevent the
في المايلد جريفز او المايلد جويتر عشان خاطر الناس اللي عندها مشكله في عينيها. ده اللي انا كنت اعرفه. لكن الايودين انا بستعمله علشان to block the thyroid hormone production.
Yes, here, but you can, yes, but here is not the question. My question is about if you have a dysfunction here. The iodine, you cannot use it as a supplement, my friend. You have to use it like radioactive, as you said. Okay, but here, what I did you get the question? My question here it is. Where is it? Yes. Which of the following minerals or supplement maybe
supplement.
okay, supplement or minerals? Yes. So we have, if you would recommend a supplement or a mineral for a patient, would you recommend him to take iodine?
No.
Okay. Yes.
Okay.
Okay. So
يعني
iodine is very important. I
القصة
know
كلها في حتة
to
supplement.
maintain the function. Iodine is important to maintain the function. That's why it's added on the most of the salts you have. You buy from the supermarket. It says it's rich with iodine for the thyroid function. Okay, but biotin, no benefit. Zinc, no benefit. Selenium, yes, there is a benefit from selenium. Okay, so the selenium here. Okay, let's go. Perfect. So far, so good. Any questions?
حلو السؤال ده على فكرة. حلو. خادع.
اوكي. يا ما انت حليته حاجة صح يا ارميا. انت حليتوش الا سؤال واحد صح من اول ما بدأنا. ركز بقى يا ارميا.
بلاش احراج. الدنيا صيام يا دكتور.
يلا يا عم خش يا عم على الكيس دي ورينا الشطارة. Case scenario, question number 1 with this case. Okay. HJ is 37 years old female patient. Her weight is 70 kilograms. Has been recently diagnosed with subclinical hypothyroidism. Has no symptoms and came to your pharmacy. Has no symptoms and came to your pharmacy with a new prescription of Eltroxine 75 micrograms per day.
دكتور
while the
معلش الكيس نفسها احنا مش شايفين حاجة. احنا ما فيش
هي دي انتوا مش شايفين السؤال؟
لا ما فيش كيس. هو عندنا كلمة فارما فري بس.
احنا شايفيها بس ممكن انت يا ارمي عامل زوم عن السكرين.
انت هتلاقيك عامل زوم يا ارمي.
يا باشا انا مش عامل حاجة والله. انا قدامي العلامة بتاعت فارما فري بس.
اما في النص الثاني من الصفحة اللي هو السيناريو
على
موجود.
الشمال. Yes. On the left.
اوكي ايوه انت صح. ميرسي يا محمد. ماشي.
وينفع تعمل زوم بس؟
عيوني يا ديفيد.
ربنا يخليك، تسلم عينيك يا دكتور.
تصدق مش عايزة تعمل زوم يا ديفيد.
معلش يا دكتور،
تمام.
مفيش مشكلة.
Oh my. I think the
سوري راحت خالص.
yes.
يا راح.
Is it better now?
كده تمام.
Okay. Okay. While yes, she has a new prescription for Eltroxine 75 micrograms. While the medication you have in stock is Centroid 50 milligram, micrograms. What would be your most suitable action here? Okay. I cannot see the screen. One moment, my friends. Sorry, my friends. Yes. Okay, dispense Centroid 50 milligram. Centroid, yes, 50 microgram, 1.5 tab per day, or refer her to another pharmacy to get Eltroxin 75 micrograms. Number C, fax the treating physician to ask for approval to dispense Centroid 50 micrograms, or ask here to come back in 2 days when you will have received Eltroxine 75. Yes. Okay, I see that we got some answers here. B, D, D, A, B, A, B, D, D, A. Most of the answers went to D, I think. So, yes. D. And B. Azz B. Mariam D. Samar D. Sarah A. ديفيد بي اللي هي A SAB زياد دي هبة دي رشمي A فادي B رنا D نهى A سمر A okay end.
Can I talk please بس يعني بعد ما تخلص او قبل ما تبلش باللي يريحك. بس انا عندي بس علشان المنتال سيت اللي عندي I fix
Yes,
it.
go ahead.
So
You have a question?
it's like, yeah, but I would rather discuss it with you after. So you explain it and then I'll discuss it with you.
Okay, so what do you think? Oh, do you have an explanation here as?
I have explanations for all, like dispense Centroid 50 and 1. This is not true because Centroid, Eltrixon and Centroid are not the same, as I heard it once.
Okay.
Refer her to another pharmacy to get Eltroxone. This is what I chose because, okay, here's the thing. Between B and D, it's not something like antibiotic that cannot be delayed. So but at the same time, you want to give the beneficence to the patient. So you want to get it as soon as possible. You don't want to. You don't want to.
This is not the trick, my friend. This is not the trick in the case. Okay, this is not. I got what you mean, but this is not. Okay, so the trick here, or the thing which is hidden here in the case, this is a new prescription. Okay. So what does it mean when you have a new prescription?
Like, is it high dose to start?
Not like that. But when you have a new prescription, you can dispense either the Centroid or Eltroxine. Okay, you can, if you have Centroid, you can dispense it, no problem, no problem. If you have Eltroxine, yes, you can dispense it, no problem.
But is it breakable?
Yes, sure, it's breakable. Yeah, you can break it.
Yeah, I've heard that they can be interchanged. So the first time
they cannot be interchangeable when the patient is taking currently Centroid. When you change him to another to Eltroxine, you have to make a follow-up after a while. Let's because this is, I think we have another question about this, about the interchangeability. Okay, but here if the patient is currently taking one of the two medications, like if I'm using Centroid, you cannot change it to me to Eltroxine. But here I have a new prescription, correct?
So it's going to be
and he has recently been diagnosed with subclinical hypothyroidism. Okay, so this is the first prescription she got. You can dispense Centroid or you can dispense Eltroxine. And this is the trick in the question.
Yeah.
Okay, just to make you, because I heard so many, because we got a case, a station in the last mock exam, something like that. And many of you have, unfortunately, didn't catch it. This is a new prescription, so you can dispense both. If you have Eltroxine in the prescription, you can dispense Centroid if this is a new medication. No problem. What is wrong? And I have written here between the brackets, levothyroxine, and this is levothyroxine as well. Correct? It's the same medication. It's only another generic.
Doctor, so يعني if you give her Synthroid, would you able to change it to Eltroxin after يعني after a month؟ لو خلص
why to change it? Is there any benefit?
لا يعني نفس الشيء, but it's
so
not
yes,
interchangeable.
the same thing.
Yeah.
You can, yes, she can keep taking Centroid,
Oh,
and
okay.
even she can change to Eltroxin. But what we do, what the action we have to do here, if the patient is currently taking Centroid, for example, and the Centroid abruptly came out of supply, as a supplier had shut down and stopped working on Centroid, and the only choice you have is Eltroxine. What we have to do here is there is an action that we can do. What do you have any idea?
Ask doctor for prescription for Ultroxin.
Ask what?
Ask doctor, get a new prescription for the available one.
What's a prescription? You have already a
Patient-
prescription for levothyroxine. Okay, my friend.
I mean, if the patient on Synthroid and the Synthroid like
went out
stock,
of went
yes.
out of supply. There is no discontinued in Canada. The Synthroid has discontinued in Canada. Okay, was discontinued. So the only choice you have is Eltroxine. What are you going
how
to
can I
do?
bill it? Okay, I'm talking like in practical life. Can we bill like another? We have to get a new prescription, same medication but different, like Ultroxin.
You can. You don't need to have a new prescription. Why to have
To
a new?
bill it at least like, right?
No, you don't
Because I
have.
don't have prescription
you
for
don't
the
have to.
Ultroxin. How can I bill it for the Ultroxin without prescription?
If you, because the patient have refills, my friend. The patient has
Refills
already
of the
refills.
Synthroid, so I'm going to refill
Yes, you are going to change it to Eltroxine, correct?
by myself.
You can do it, but you have no choice. You have to, because there is no more Synthroid in the market.
Yeah,
Right.
you're talking therapeutically, sure, but I think I'm talking practically. I think we need to get prescription to bill it under the new
No,
medication.
no, this is
Because you
no,
have to scan, right? At least to
No.
scan prescription under the new medication.
no, it's not correct, my friend. It's not correct. What are you saying is totally wrong. Sorry. Okay, so okay, Iman Makar is saying blood work. What do you mean by blood work, Iman? Eltroxine is brand. Okay, so guys, the problem here is the trick here. Eltroxine and Synthroid are not interchangeable. What does it mean? This means there's a discrepancy in the bioequivalency of each generic. Okay, okay. This is a trick. Levothyroxine is a pro-hormone. This means when the patient takes the levothyroxine, his body adapts the dose to the body needs. Okay, the body absorb the levothyroxine, makes his adaptation, and give his body the necessary the necessary thyroid hormone needed, and for the remaining, the body dispose or excrete the extra hormones. Okay, the trick here, both medications, Eltroxine and Synthroid, are not bioequivalency similar. Okay, there is a discrepancy. This is the reason why they are not interchangeable. What you have to do here, if the patient is taking Synthroid and Synthroid went out of supply or discontinued, for example, you can change it to Eltroxine, but the patient has to go a blood work in 6 weeks. Okay, to make sure the same dose, for example, for Eltroxine, gives the same effectiveness of the other dose of Synthroid. The 50 micrograms of Eltroxine gives the same efficacy of the 50 microgram of Synthroid. Okay, that's it. That's it. The only trick that you have here is to make a blood work in 6 weeks. You can change and everything is okay, but you have to advise the doctor when the patient is already taken one of them and you decided to change it to another generic, you have to advise the doctor to request a blood work in 6 weeks. Okay. Okay, so let's repeat it in Arabic for the other colleagues.
معلش كده بقى الإجابة
So-
هتبقى إيه؟ معلش كده الإجابة هتبقى إيه؟
بصوا بقى، صلوا بينا على النبي. دلوقتي يا شباب، صلوا على النبي يا ارميا. دلوقتي
معلش انت استاذ
اللي بيحصل ايه دلوقتي؟ السنترويد sorry Rashmi, I have to clarify it in Arabic. Okay, if you have any question let me know. Okay, اللي بيحصل يا شباب سريعا ان انت ممكن الاثنين مش interchangeable، الالتروكسين والتاني، عشان في اختلاف في البايو ايكويفالنسي. اوكي، الجسم الانسان بياخد الليفوثايروكسين which is pro هرمون. يعني ايه برو هرمون؟ يعني الجسم بياخده، بيعمل له ميتابوليزم، وبياخد اللي هو عايزه وبيرمي الباقي. اوكي، ده الميزه بتاعت الليفوثايروكسين او التي 4 عن التي 3. اوكي، ده الميزه الاساسيه عن التي 4 عن التي 3، عشان كده اغلب الادويه تي 4 مش تي 3. اوكي، اللي هو الان اكتيف فورم، عشان الجسم بياخده بيظبط اللي هو عايزه وبيرمي الباقي. اوكي، فاللي بيحصل ايه، ان الاثنين مش زي بعض في النتيجه في الحته دي. ده بيدي جرعه ليفوثايروكسين مختلفه عن الثاني. فال 50 مايكرو جرام من السنترويد ممكن ما تبقاش 50 مايكرو جرام للالتروكسين، ممكن تبقى اعلى او اقل. فعشان كده بعد 6 اسابيع لازم العيان يعمل بلاد وورك لو انت هتغير، لو العيان اوريدي بياخد. لكن لو انت عندك نيو بريسكريبشن، انت ممكن تصرف سنترويد او ممكن تصرف التروكسين، بس يفضل العيان ماشي على نفس الدواء بعد كده. لو هتغير يبقى لازم تطلب بلاد وورك بعد 6 اسابيع. ده البروتوكول، وده المونوجراف، وده الجايد لاينز. اوكي، ذاتس ات. سو فار سو جود. وضحت؟
ايه الاجابه في الاخر يعني؟
حد يقول لي بقى ايه الاجابه؟ what's the answer what's the answer here؟ ايه، برافو 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 برافو. It's A. Then Centroid 50 microgram, 1.5 tablet per day. That's it.
So we just treat it like any other medication. That's as simple as this. And as long as it's the first time prescription, that's it.
Yes, it's first time prescription. Yes, dispense. You
No
can
matter
dispense
the brand,
everything
you
in
just
Centroid.
dispense the actual active ingredient, and as long as it's the first time. The
Yes.
only difference is because they have different interchange, like
Only
equivalent.
yes.
Yeah.
Yes. The trick here, the most of you are يعني بيغلط في الحته دي عشان فاكر ان هو interchangeable. ما ينفعش ان انا جات لي نيو بريسكريبشن I cannot dispense the other generic. لا طبعا
طيب
غلط.
دكتور، ما هو كل الادويه بصراحه الجينريكس كلهم فيهم، حتى الجينريكس كلهم فيهم يعني مش 100% البايو equivalency. Let's say citalopram, escitalopram, any of them, like all of them, like it's between 85 to 125 or something like that. So it's
No,
not
but
like 100. Yeah.
yes, بس ممكن، بس برضو no guidelines dictate that we have to make a blood work or
دكتور
make
لو
it.
سمحت،
But
معلش يا
some
دكتور، هو
some
انا
patients,
هو
by the
انا
way,
كنت
some patients, one moment, Army. Some patients
ماشي.
may be sensitive to a generic to another rather than another.
Yeah.
Like example, some patients are very sensitive or have allergy, for example, or intolerance to teva pantoprazole, while when they are taking apopantoprazole, they are fine. So
That's
the
correct.
ingredient or
Yeah.
the excipient itself could differ.
Yeah, that's correct. Okay, thank you, doctor.
Armia, yes. Go.
دكتور معلش، هو انا كنت مجاوب حقيقه سي. ليه بقى؟ انا لازم في كل الحالات، انا يعني حقيقه كنت عارف جزء من المعلومه ان الاثنين بايو سيميلر ومش انترتشنجبل، ولازم نعمل بلاد ورك. دي كانت كيسه اوسكي كانوا حكوا عنها قبل كده. بس
Okay.
انا اللي بتكلم،
So
بس انا هنا في اجابه السؤال ده انا ما اخترتش. مش ممكن نرجع للسؤال تاني؟ حضرتك ما كتبت يعني، حضرتك رحت السؤال اللي بعده. في اجابه السؤال ده احنا هنا اعمل اول فاكس واصرف السنسوريت 50. هو مش لازم ادي قرص ونص، انا هعمل فاكس عشان المريض ده هيعمل بلاد ورك بعد 6، لان ممكن السنسوريت 50 يدي لي نفس الايفكت بتاع الاتروكسين 75 كويس، وممكن لا. فانا بعمل فاكس بقول للدكتور انت كاتب لي كذا، انا هغير بكذا، فلازم اعمل دوكيومنت بده وابعت له فاكس واخد الابروفال بتاعه.
no. Here you are decreasing the dose.
معلش انا عندي سؤال يا دكتور،
Here you
هو
are decreasing.
هياخد 1 تابلت اند هاف عادي، ولا الكومبلاينس هيبقى عنده مشكله، ولا دونت اسيوم؟
Don't assume. Don't assume.
استنى يا ديفيد، كومبلاينس
You have a prescription for 75, correct? Dispense the 75. That's it. Don't assume. It's your role as a pharmacist to make the follow-up on the efficacy, safety, and compliance. This is the main role of the pharmacist. Efficacy, safety, compliance. Okay? That's it.
Okay.
But here, no, you by your answer, Armia, you are decreasing the dose from 75 to 50, which is wrong. Okay, you have the same molecule, which is levothyroxine. You have to dispense the same strength. Okay, so
thank
let's
you.
proceed, my friends. This is the second question. Second question. Upon following up with HJ, you have noticed that she's always late in picking up, as David said, picking up her medications despite your previous trial to improve her compliance. How would you act? Serve her levothyroxine in a blister bag so she can remember taking it? Ask as she has no symptoms, so missing some pills within the months is not important, especially that levothyroxine has long half-life. Advise her that she can take the 7 tabs of the week at one day if necessary, and upon approval of her physician, refer her to the treating physician for re-evaluation. Okay, go ahead. Yes, we have Rima, Summer C, David C, Azdi, Siba, Afandi C, David, yes, C, C, D, C. Mm-hmm. We have 4 or 5 C's, or even 6 C's, and 1 D. Azdi, Hala A. Mariam A. Rashmi A. Okay. No A or D.
ما تعرفش سبب الانكمبلاينس اصلا، وانت اصلا تغيرت النسب بال like now she's been like that for a long time. She needs a reassessment اصلا. So that's what I was thinking. You can't just decide. You don't know the reason اصلا she's not picking up her medication. So the
Okay.
only right answer that I found here is she needs a reevaluating. And then when you know the answer, you can choose from these options.
Okay. Good point. Good point, guys. Okay, so this is the end. Okay, here. Okay, the question says that she had, yes, she's incompliant with the medication despite your previous trial to improve her compliance. So you have already tried to improve the compliance, correct? Like you offer, maybe you offer blister bag, you offered something, you have to take your medication because this is important, and etc, etc, etc. Okay. Okay, refer her to the treating physician for re-evaluation. Okay. What do you think about this answer, and what do you think about number C? Advise her that she can take the 7 tablets of the week at one day if necessary and upon approval of her doctor.
So what I think for D, she doesn't have any symptoms.
فايد
Maybe
صوتك
like
مش باين يا فايد.
mentioned
فايد I cannot
symptoms.
hear you.
The only problem
فايد I can't hear you my
late
friend.
picking up.
حد سامع فايد يا دكاترة؟
لا.
بقول لك دكتور، بقول لك
حاول تقرب من الواي فاي بتاعك.
دكتور sorry internet is cutting through.
Okay, so yes, here we have, my friends, here we have 2 answers. One of them is correct. Okay, refer to physician, this could be right. Okay, but here what you have, do you know, have you ever heard about the weekly dosage of thyroid, of the levothyroxine? Have you
هو
ever?
دكتور هي دي صحيحة أصلا، بس ممكن أصلا من السايد effect she's not taking that. We don't
not
have
that-
enough information. That's
No,
fine.
there is no, usually there is no side effect. There's no side effect from this approach. You can give the 7 tablets once per day. Why we can give that? Because levothyroxine has a half-life of almost 7 days.
Well, true, doctor, I agree with you. But if she said that she's not taking the medication because she's forgetting, okay, that's the right answer in my opinion. But here there is no specifications. Like she could be she doesn't like taking medications aslan.
Yes,
So
but I'm not saying, by the way, I'm not saying this is wrong. But here you have what? You
this
have
is wrong. This
approval
is
of your
right answer.
physician.
This is a right answer. It could happen. Like we can do that for levothyroxine.
Yes, correct. That's it. Okay. So anyhow, you have tried so many times with her before to take her medication, and the problem is she's not compliant. If she's not compliant, you have a weekly approach, weekly dosing approach. You can try, but you have to take the approval from the physician. I would like to make that and that for this patient because she's not compliant and she's not taking any medication. Okay? Because here you are advising the doctor and let him know, and you facilitate the life of the patients. She will only take 7 tablets once per day or once per week, like every Thursday or every other day. Okay, so this is could be a very effective approach, by the way. Okay, but referral to physician, yes, you can refer her, but no problem. But you are not answering the issue here. Okay, so this is for me. I think this is the easy answer. Refer her and let the doctor deal with her. Okay, but for me, I think you can advise the doctor and offer the solution at the same time.
If there was another option that I can choose, and I think personally, just my opinion, doctor,
Yes.
if there is an option, just ask why she is not compliant with the medication. And then we can decide if she says, oh, I
Correct.
keep forgetting taking the medication. Okay, then it's C.
Correct. If this is an OSCE station, yes, you can ask. But here you don't have. You have to deal with the available information. Okay, you have to choose the best answer. By the way, in some questions you may find 2 or 3 valid answers, but you have to pick up one answer, only one answer, which is the most appropriate or most relevant.
دكتور ما هي دي الترك اللي بيعملوها دايما.
طبعا.
For me, like it's just my personal opinion and it doesn't matter. I know this step is right, for sure, number C. But at the same time, I think if they bring such a question, they want to trick everyone by not mentioning why there's multiple options that she cannot be compliant with.
This is a very important question. This is the key question that you have to ask. If there is an OSCE station, yes, 100% correct. You have to ask for what reason. Are you forgetting? Do you have any problem with the medication? You feel that this medication is not doing good with you? What's the reason exactly?
Yeah.
Okay. Yes, as you said, perfect. This is the right approach. But here you have a rare information, or excuse me, a little information that you have to deal with. Okay. So I think C is the correct. But D, by the way, again, I believe D is not wrong. But C is more relevant. For me, C is more relevant. Okay. Okay. Next, for what reason could HJ be prescribed levothyroxine? Yes. For what reason? To avoid develop clinical hypothyroidism with symptoms. She may be pregnant. She may develop myxedema coma if not properly treated. She may be overweight. Okay, Iman B, Sarah A, David B, Az Hamza. Wow. C. Okay. B. هلا B. هبة B. سارة A. زياد A. فايد B. Rana C. Oh, we got all the answers except D. C. مش عارف، مش فاهمك يا عز. NVM, never mind. About C, never mind. Yes. NVM about C, never mind about C. مش عايز A طيب. What do you think? What's your answer يا عم عز؟
اللي قلناه دكتور هي بتعالج السب كلينيكال في حالات معينة، بس اللي قلناها قبل شوية.
Yes.
مم.
So what's the answer? Give me your answer.
pregnant.
ماشي يا عم متشكرين. Okay, so this is the end. Yes. Guys, we were talking about this question, correct? We said four situations or four conditions that we have to treat the subclinical hypothyroidism, correct? What are they, guys? What are the four conditions?
For الاتريال fibrillation, الالدرلي والبريجنسي، وفي واحدة رابعة بس مش
No, my friend, atrial fibrillation والelderly ده في
بالهايبر
الهايبر.
صحيح. لا بالهايبوثايرودism.
Yes, but in
Yeah.
hypo pregnancy
الديسليبيديميا والبريجنسي والسيمبتوم.
what?
Dyslipidemia, pregnancy, and symptom.
Symptoms, yes. But
Yeah.
there is more. There is more, I think.
I just don't remember the
Hyper
lecture.
pregnancy, dyslipidemia. Yes, if the TSH is more than 10. If the TSH is more than 10. Yes. Okay, perfect. So the answer here is a pregnancy. She may be pregnant, my friend. That's why the doctor is willing to treat her for the subclinical hypothyroidism. It's very easy question. It's very easy. Why you answered C and D and okay, no problem. Okay. Oh, question number 4. What do you think about HJ's levothyroxine dose? Okay, she's taken 75, correct? Here is the scenario. She's 37 years old. Her weight is 70. No symptoms, and the dose is 75. Perfect. What do you think about the dose? It seems correct, as levothyroxine dose for treatment of subclinical hypothyroidism is usually lower than symptomatic hypothyroidism. It seems wrong, as it's too low, as the dose should be 1.5 micro per kilo per day. It seems wrong, as it's too high, as the starting dose should be 25 to 50. None of the above. Let's go. Let's go. Let's go. Let's go. Okay, David and Summer C. Leah is contributing. C is D. None of the above. Rima B. Sarah D. D. D B. Okay, Rashmi B. Rashmi Agrawal. It's Agraval or Agrawal?
Agrawal.
Agrawal.
Yep.
Okay, B. Can we have more answers? 2 or 3 more answers? هلا سي. يلا واحدة كمان. End. Okay. And okay. A normal or clinical hypothyroidism. Do you know the difference? Do we give the same dose? Do we give higher dose? الو الصوت قطع ولا حاجة؟ يا شباب.
Now it's good.
That's good. Okay, perfect. Do we give the same dose? Do we give a different dose? What do we give? Actually, what is the difference? How we treat the hypo, the subclinical, and the clinical? Okay, so for the clinical, what is the dose for clinical hypothyroidism? How much we give the levothyroxine?
It's answer B, like 1.6 microgram per kg per day.
Yes, correct. This is for the clinical or the no symptomatic hypothyroidism. Okay. For subclinical, we give 1 microgram per kg per day. Okay. It's only 1 microgram around. So the dose here, she weighs 70 and the dose 75. So it's almost 1 microgram. So the dose is fine. Okay. The dose is fine. It seems correct that the levothyroxine dose for the treatment of subclinical is usually lower than symptomatic hypothyroidism. Okay, do we need to titrate the levothyroxine? Do we titrate?
Yes.
You need to titrate the levothyroxine dose?
No, I don't.
In this
think so.
case,
No.
or
In
normal.
general, my friend, in general.
Yes, yes.
Yes, yes.
Why?
I guess we only titrate in angina or cardiovascular risk patients.
Yes. If there is no risk factors, no problem, you don't need to titrate. Why do we don't need to titrate? I mentioned the answer a few minutes ago, if you can remember. Why?
Because it's a pro-hormone.
Yes, it's a pro-hormone. Okay, so the body will take it, metabolize it, extract the necessary amount, and discard or excrete the okay.
دكتور معلش ممكن تقول لنا الدوز تاني الاختلاف بين السب كلينيكال
It's one for the clinical, it's written here as in the CTC 1.6 microgram per kg per day. Okay, for the subclinical, it's 1 microgram. It's only 1. Yes. Okay, that's it. Okay, my friends. Okay. It's good. It's
Doctor,
good
I have a question before we move on.
Yes, go ahead.
معلش Doctor, regarding the question about the Thyroid and the interchangeable between brands and so on. So we have two في حالتين. الحالة الأولانية إن أنا آسفة على الصوت. الحالة الأولانية إن يكون البيشنت ده أول مرة هياخد الميديكيشن فخلاص it's okay يعني بس should we fax the doctor before we give him the other brand?
No.
Okay, so just give him the other brand. طيب بالنسبة للحالة الثانية لا.
ما فيش لا احنا
نعم.
بيجي لنا روشتات بالهبل التروكسين او ليفوثايروكسين او سنترويد واحنا بندسبنس اللي على مزاجنا ما لو هي اول مره فاهمه
تمام طب لو مش اول مره بقى والميديكيشن اون باك اوردر مثلا
لا هنا لازم you have to advise the doctor and make the blood work in 6 weeks to make sure that it's the same dose.
Okay.
معلش هو انت بتصرف انهي واحد على اكوردنج على ايه؟ على البرايس مثلا يعني ولا على هو كفرد ولا مش كفرد ولا ايه بالظبط؟
حسب مزاجك عندك الستوك ما عندكش الكفرد مش كفرد بس هو mainly it's centroid which is always covered. For L-tropine some companies are not covering it. Okay, centroid is a preferred generic.
يعني الرام كيو مثلا بيكفرز
centroid بيكفر I think the RAM Q covers both. I think it covers both, but for its coverage for the centroid is more than its coverage for L-tropine. Yes, L-tropine usually it's more expensive than centroid.
اوكي.
حكايه ايه الحاله اللي بعمل فيها التيتريشن في الانجينا وحاجه تانية ولا انجينا بس؟
Atrial fibrillation, angina, if there is any problem in the heart. If the cardiac patient, if it's a cardiac patient. Okay, my friends, let's proceed.
بس ده في
Those-
السب كلينيكال بس يا دكتور، صح؟
ايه يا باشا؟
في السب كلينيكال بس ولا في السب
يعني-
كلينيك؟
What do you mean?
يعني بنعمل يعني ما بنعملش دوز تايتريشن في السب كلينيكال، انما في الكلينيكال بنعمل عادي.
ما بتعملش
according
ليه يا عم؟ هتتريت ليه يا عم؟
according للسيمتومز وتي اس اتش.
هو الدكتور بيحسب الدوز وبيفقعها له على طول. That's it. You mean in cardiac patient? If it's a cardiac patient or what?
لا يعني لو حتى مش كاردياك بيشنت انا متهيألي يعني ممكن دي تكون
No. We don't titrate with Centroid or levothyroxine. We don't titrate. The doctor may prescribe a low dose. Yes, the doctor may prescribe a low dose like a precaution or like a precocious measure or something. But according to the guidelines or the monograph, no need to titrate the dose. Okay. But usually, yes, they start with a low dose and see how the things go.
يرفعوا. ده حتى في ناس بتبتدي ب 12 ونص عشان تبقى خايفه من السايد افكت.
Yes. It's like for like a precaution or something. Okay. So question number 5. Dose reduction of HG's dose of levothyroxine may be required in the following settings, except. Okay, the answer, as we said, it's A. For this question, for question number 4, the answer is A. Dose reduction of HG's dose of levothyroxine may be required in the following settings, except. Postpartum, as the dose should be reduced to the pre-pregnancy maintenance dose. Weight loss of more than 10% of her body weight. Increased thyroid hormone absorption. Concomitant intake of carbamazepine. Okay, we can make dose reduction in all these settings except one that we cannot reduce the dose. Okay. Rima. Yes, Rima D. Heba D. Faid D. Ziyad A. Izz D. David D. Leah D. D. So all is D except Ziyad went for A. Postpartum as a dose, yes. Okay. Most of you are going to D. Okay. And mesh. Okay. All your answers are correct. Except Ziyad. Except Ziyad. Oh, yeah, Ziyad. After the delivery or postpartum, we need to reduce the dose. Okay, and get it back to the pre-pregnancy dose. Okay, so we can reduce the dose after the delivery. Yes, correct. Carbamazepine is inducer, correct? So you may need to increase the dose, not to decrease the dose. You can decrease the dose if the thyroid hormone absorption increased. Yes, you have to decrease the dose. If she lost weight of more than 10%, you have to decrease the dose. If she delivered, okay, and she's in postpartum period, you have to decrease the dose. Except if she's taking carbamazepine concomitantly, so you have to increase the dose. Okay, that's it. Okay. Let's proceed. Yes, we have some miscellaneous questions. Subclinical and cyber diagnosis, when to treat. Yes, we addressed that. Myxedema, coma, and thyroid hormone. What are the differences? Causes, symptoms, treatment. Yes. What are the differences between myxedema, coma, and thyroid storm? بسرعة. And symptoms, treatment. بسرعة. Rashmi, go ahead.
Please.
What's your answer here? Can you see the question?
Okay.
There is no, it's not an MCQ. Okay. This one we answered already. Selenium role, dose, yes. Okay. Would you like to went through this question quickly or going for, I think we have afterward some questions and cases on diabetes. Would you like to go these questions quickly? This question is important, I think. Selenium role, Lugol solution question, yes. Levothyroxine dosing in pediatric, young, geriatric population, dose titration and dose adjustment. Levothyroxine. Yes, so myxedema, coma, and thyroid hormone. What are the differences?
ممكن أجاوب؟
What does it mean? What does it mean, myxedema, coma, and thyroid hormone?
الماكسديما كوما it's complication من الهايبوثايروديزم. اوكي بس ف الجسم بيعوض دوت.
In English, please, Armin, can you keep it in English?
Okay. Myxedema coma is an extreme complication of the hypothyroidism in a patients have multiple organ abnormalities. Okay.
Yes.
That's it. The typical symptoms of it is hypotension and the decrease the level of consciousness. Okay. And it is a medical emergency. It is a medical emergency. And the treatment is by levothyroxine IV, I think from 300 or 500 microgram initially.
IV?
Yes. We give levothyroxine IV.
What about the oral?
Okay, followed by the oral. No, in the myxedema coma, it is an emergency case. I don't give oral in myxedema coma.
What is the problem if you give?
Because I need to
if you give him a high dose?
Because the myxedema coma, there is an hypotension and decreased level of consciousness.
If he's if he's not in coma, like if he's hypotension, okay, and he's maybe, yes, you're thinking about the decreased level of consciousness. Okay, but even if he can swallow, what if he can swallow?
Even he can swallow, I give IV because it's a medical emergency.
You can. Okay, so you don't want to give the oral, correct?
No.
Okay.
I give it high dose of the levothyroxine IV initially.
Okay. What else you get?
Yes, I give also concomitant with the.
By the way, in myxedema coma, okay, there is the absorption of levothyroxine is almost stopped from the GIT. This is the main reason you don't give oral. Okay, this is the main reason why you don't give oral in myxedema coma, because the levothyroxine is not going to be absorbed from the GIT.
Okay. And we give the with the
and of course level of consciousness, of course. Go ahead.
We give with the levothyroxine IV. We give it hydrocortisone or corticosteroid.
For what reason? Cortisone?
For the hypotension.
Okay, something else?
No, that's what I know about the myxedema coma. It is everything.
Okay, we give corticosteroid. Okay. It could help in the hypertension, yes, as you said, but we give it usually for the adrenal insufficiency. okay, for the corticosteroid. When the patient went in coma or something, there could be adrenal insufficiency. The adrenal gland could stop working. Okay, so we'll give the cortisone to avoid that. Okay, thyroid hormone. Okay, perfect, Armia. Thank you so much. What about the thyroid storm?
The thyroid storm, it is untreated or undertreated hypothyroidism, and it is also a medical emergency.
Okay, perfect. We treat it with what?
It is life-threatening agent case. Sorry.
We treat it with what? What
We
medication?
treated. Okay, we treated it with supportive therapy. We give antithyroid medication. We give beta blocker and give corticosteroid.
Okay, perfect.
And
Thank you.
for the hyperthermia, which is usually associated
Yes.
with the thyroid
Yes.
storm, we give acetaminophen.
Okay, perfect. الله ينور يا رب. مية مية.
But I have an information for the hypothermia. We avoid the non-steroidal and we avoid the aspirin in this case because the protein binding displacement of the antithyroid medication which I give.
Yes.
That's it.
Give us acetaminophen. Correct. Okay, selenium role. I think we discussed that. Lugol solution uses and counseling. Lugol solution. What are the counseling? Okay, it stains. Okay.
Counseling ممكن نديها
When the patient can take Lugols, for what reason we give Lugol solution?
في severe hypothyroidism.
Okay, when he can take it, when the patient can take it.
When?
Yes, exactly, Rima. Should be taken before 1 hour before. Before 1 hour before.
1
No,
hour
1
after
hour after.
البروفايل
No.
thyroxine.
Before or after?
After.
Yes.
After. No. 1 after. 1
Yes.
hour after the administration of the antithyroid.
Yes, correct. Okay.
وممكن يتاخد مع can be taken with orange juice and milk.
Yes, can be taken with oral juice and milk. How much it contains iodine? How much iodine it contains?
مهم قوي تعرف
What's the
يعني.
concentration? Yes, طبعا. 6.3 milligram per drop. Correct. الله ينور. Perfect. Okay, that's it. Okay, 100. Levothyroxine dosing in pediatric. I think we discussed that. In young, pediatric, and geriatric. What are the dosing of levothyroxine? Quick. Levothyroxine dosing. Pediatric, what is the dose? What is the dose in children and young geriatric population? يلا يا شباب بسرعة.
دكتور هو الكلام ده مش مكتوب في CTC يعني هو مكتوب الادلت دوز بس.
No, you have the dose for the pediatric as well. Yes, correct. Yes, for the elderly, yes, we start with this dose, 1.6 microgram, and for pediatrics, my friend, we have the dose. You have the dose in the CTC for the children.
No we don't.
والنعمة عندكم. ولو طلعتها لك دلوقتي هديك الايميل تحولي لي $100.
بس كده.
اوكي طلعوها احسن بدل ما اطلعها لكم.
I'm checking the RxTX online just in case I have an old copy of the CTC.
Yes, you will have it. I swear to God. Okay, so the dose in pediatric population, it's from guys, how much in children, in newborn. خلينا في النيوبورن بلاش يعني مكتوبة نيوبورن باين.
انا ما تسالنيش على الدوزج.
Okay.
دكتور
دكتور،
هو الدوز
اوكي
For
اتفضلي.
levothyroxine, I think the dose is important. For the levothyroxine, yes, I think it's important.
بس دكتور it's not in CTC. انا طلعتها من المونوجراف بتاع السنترويد من على الRxCx.
Fayed, okay, Fayed, did you get the dose from the CTC or from where? CTC اهو راجل اهو زميلك اهو داخل معاكي نفس الامتحان.
دكتور ما انا فاتحاه والله قدامي. طب فين ده؟ in which area؟
أهو، ابن العراق اهو طلع الاجابه موجوده وانا مطلعها من CTC. بصي بس كويس يا دكتور.
حاضر.
موجود في CTC. Okay,
دكتور
so
من
this is
12
the dose
ونص ل
from
25
we give a higher
من
dose.
12
Yes, we give a higher dose. So from 50 to 20 microgram per kilogram. From 15 to 20 microgram per kilogram in children. Okay, we give a higher dose than adults طبعا. No ايه يا عم 10. ايوه صح 10 ل 15. هو مين اللي قال من 20 ل 15 دي؟ From 10 هي 10 folds اعلى من الثانيه. يا عم انت ما تلخبطناش، هي من 16 كمان. From 10 to 16 I think. From 10 to 16 microgram or something like that. Anyhow, it's about 10 folds the adult dose. Okay. Okay. Levothyroxine dose in subclinical hypothyroidism, we say that it's 1 microgram per kilogram. Okay, propylthyrosile and methimazole, differences and preferences. Which one is preferred over the other one? And what type of monitoring or blood work that we are doing for both?
Over propylthyrosile except in pregnancy the other way.
Eh? Repeat your eyes.
Methimazole is preferred over propylthyrosile except in pregnancy. It's the other way. Propylthyrosile is preferred. That's what I know.
In pregnancy?
First trimester only.
Yes.
Yeah. And we
First
double the dose, right?
What?
We double the dose in pregnancy.
You double the dose?
No,
لا انت ما بتعملش
per
دبل
week, I
الدوز.
think.
لا انت بتدي 2 extra tablet per week.
Right.
Yes. You increase the dose. You increase the dose by about 15% or 15 to 25%.
Yeah.
But it's not this one, guys. It's
levothyroxine.
It is the levothyroxine.
thyroxine. Yes, it's not the متلخبطناش بقى.
Even this one, Doctor.
لا
Oh,
this
يا
one
بيه.
we use the lowest dose possible.
Yes. No يا بيه.
لا يا عم انت
المصدر اللي قريت منه غلط.
يا عم عز ما تلخبطناش يا عم عز.
ما هو انا قريت من مصدر غلط اصلا.
انت قريت منين بس؟
لا خلاص.
بص يا عز دكتور بعد اذنك، بص يا عز، المشكله في البريجننسي ان كل هرموناتها بتبقى اعلى من الطبيعي. خلاص؟
أيوة.
فدلوقتي هي الست دي لو عندها هايبوثايروديزم هي محتاجه هرمون اكتر، فبالتالي بديها 2 اكسترا دوز من الليفوثايروكسين. طب هي لو هي عندها هايبر خلاص، فانا بديها الدوز العاديه بتاعت الميثامازول بتاعت بس.
Okay, we increase the dose only for levothyroxine. For those medications, we don't increase the dose in pregnancy. Okay. In general, methimazole is the preferred one in most cases, except in the first trimester that we privilege the propylthyrosine over it. Okay. Okay. For the monitoring and pre-treatment consideration, AST, ALT, Syriat, CBC, yes. Okay, when to tell the patient to see the doctor? When you can tell the patient that you have to see the doctor? If rash, correct?
Rash or fever, sore
Happen?
throat, jaundice.
Yes. Rash or fever, any signs of infection. Okay, this is very important. Okay, so levothyroxine, yes, if the patient misses a dose of levothyroxine, what we should do? What should we do? What should we do? يا
I
ارميا.
guess
ايوه يا
I guess
باشا، انا
بلاش
عندي
ارميا،
كل.
خلاص بلاش انت يا ارميا. ريح شوية. قول يا
باشا انا تعبت
دكتورة
معاك
سارة.
النهارده.
ريحي ارميا شوية يا دكتورة سارة. ارميا وعز تعبوا النهارده.
Doctor, I guess he should take it as soon as possible unless if it's يعني ميعاد الجرعة التانية he should skip it.
Should skip it. Okay. Any
Yeah,
other
بس طبعا يعني يكونوا on empty stomach ونفس ال precautions دي يعني.
Okay. Can we double the dose?
No, we can't.
No, we can. We can.
We
double.
can. We can? Oh, okay.
Yes, we can. As we said, levothyroxine has a long half-life. So it's about 7 days or something. So yes, you can double the dose. Okay? You can take 2 doses together if you missed. And by the way, it's written in the monograph.
لا وممكن ناخد
Yes,
السبع
exactly.
حبايات once per week.
Yes, بالظبط. So as Armia and the Iman said, yes, we can even take the 7 tablets once a day. But in this approach, we have to get approval from the physician. Huh? Okay.
لا هو مكتوب يا دكتور في المونوجراف إنه we should get consult from the doctor if more than 2 tablets are missed. لكن if one فعلا we should take it with the next dose.
Oh, excuse me, repeat that.
So they wrote in the monograph that a missed dose of 1 tablet can be taken with the next dose. But if more than 2 tablets are missed, the patient should consult with their doctor.
Yes, if more than 2 tablets, yes, correct.
Yes.
That's it. But yes, you can double the dose. Here we are talking if he missed the dose. Yes, if 1 dose, yes, he can double the dose. But as I said, if you recommend the patient to take 7 tablets at once, so he has to go to the doctor. Okay, switch of levothyroxine from one generic to another. We killed this in our discussion. وهنتكلمنا فيها كتير. What would you think if your patient? Yes, here we go. What would you think, or what would you do if you would see a patient on 300 or 400 microgram levothyroxine per day? This is a normal dose. This is what's the first thing that would pop up in your head?
لا دي الدوز دي بتاعت الماكسديما بومب.
En anglais, monsieur Armia, s'il vous plaît.
نعم ما انا قلت.
In English, please.
Okay, these dose with 300 to 400 microgram levothyroxine, which is given in IV, it is the dose of the myxedema coma. Okay.
معلش ايه؟ ميكسيديما كوما. If you have the patient is taken this is a medication. This is a dose in his profile. It's not an emergency case here. The patient is taken 300 microgram or 400 microgram per levothyroxine per day.
We check for cardiovascular side effects if there is any.
Okay.
First, and then.
Okay, this is a normal dose.
It could go up. I know people take it like 200. I know 250 maybe. I don't know.
Yes.
Yeah, it could be normal.
As 200 and 250, yes. But for 300 or 400, there's something wrong. The patient could not be compliant, or the patient could not take in the medication every day. Okay, that's why the doctor decided to increase the dose to get the results. The patient could take the medication with calcium, iron, any other thing. There may be a problem in the absorption in his stomach, even in some celiac disease. In some celiac patients, there could be a decreased absorption of levothyroxine. Okay, so you should investigate other possibilities here. If you see such a dose in the patient profile, this is an indication there is a problem in terms of compliance, absorption, drug interaction, any other problem. Okay, but this is not normal. Usually, most of the patients will not exceed 200 or 250 microgram. Okay. Also for weight loss attempt, what do you mean? Maybe take it with milk? Yes, this could be a reason. Yes, so drug interaction compliance, absorption problem, any other thing. Okay, my friend, you will have here some notes and some information. It's I think it's important to read. You can read it by yourself. Pregnancy, methimazole. Okay, what about if you, okay, this is a common case, by the way. Okay, I have a question. Levothyroxine dose, yes. Yeah. When to increase the dose, when to decrease the dose. Notes, yes. You can read all those notes. And weekly dosing of levothyroxine, selenium. Yes, diabetes بقى. ندخل للوحش الديابيتس حبيبنا. Okay, I have a question. What would you do if you see a patient that you serve this patient all his medication in a blister bag and you give in the same slot levothyroxine with calcium? Okay, you give both at the same time in the morning. Okay, you know the blister bag, correct? In the blister bag there are like four slots. In one you put in the first one you put calcium, levothyroxine with other medications. Okay, and the patient is taking both together, the calcium and the levothyroxine. And when you notice that, you asked him about what about your thyroid gland function? Are they good? Is there is a problem or is there is anything? And he told you, Wallahi, my doctor told me everything is okay. What would you recommend here?
Keep it as it is.
even when you know that there's interaction?
Yes, but his blood levels is controlled this way, so yeah, keep it.
We can also decrease the dose and separate them.
Mm-hmm. Okay.
Now, doctor, it takes them a lot of time to regulate it, to manage the dose to be stable.
Yes.
فطالما هو بياخد الدوز دي مع الكالسيوم and he's good, خلاص then he's good.
Yes, he's good. سيب الجود في حاله، انت هنقعد نلعب ليه؟
ما انا مش عارفه، انا مقتنعه بكده بصراحه. اصل السؤال ده قابلني قبل كده ويعني
بس خلاص انت مرتاح كده يا حبيبي، خلاص يا عم خدهم. بس خلاص مالناش دعوه. مش هو everything is good so leave it as it is. No need to intervene here. No need to make any
هو دكتور زي ما قالت ايمان في الحته الكالسيوم، احنا طالما هو مرتاح والبلاد ورك بتاعه كويس keep it and monitoring بس مش اكتر يعني.
Yes, no, just that. Simply speaking, yes. Do nothing. Okay.
ونفس الكيس لو هو بياخدها مع الاكل او بعد الاكل، هو المفروض الليفوثايروكسين بيتاخد at the before breakfast from 2 hours or 1 hour before the breakfast. لكن لو جه patient وقال لك انا باخدها بالليل بعد الفطار مثلا، هتعمل blood work وتشوف لو هو stable بتسيبه زي ما هو خلاص.
Yes, leave it. Even if he's taken the levothyroxine with calcium or any other thing. Don't make any intervention. Okay, let's proceed. يلا بينا diabetes. نصحى بقى كده في الدايابيتس، نصحى مع بعض
شويه.
خلاص نمنا بقى كتير في الثيرويد، نصحى بقى شويه بقى. تمام. عليكم تعليقات على اسئله الثيرويد؟ حد عايز يسال على حاجه؟
انا بس معلش، انا فقدت الحته اللي هي بتاعت حضرتك سالت عليها، بتاعت من 300 400 مايكرو جرام دي. حضرتك لو هو بياخد الجزء دي نعمل ايه؟
اهو
الصوت
بص يا باشا.
قطع عندي.
Here it is. Yes, few patients require doses greater than 200 microgram per day. As an adequate response to daily doses to 300 or 400, and may suggest malabsorption, poor patient compliance, or drug interaction. This could be the reasons. Okay.
اوكي.
So
زي في حالة الكربامازيبين.
usually the maximum dose is 200, 250.
زي في حالة الكربامازيبين مش كده؟
What do you mean? لو في drug interaction, yes, of
لو
course.
المريض ده
Yes,
بياخد انديوسر زي الكربامازين زي
yes, could happen. Yes, we have a question. Should we separate the centroid from the blister, as some people say so? No. ده أكتر دواء بيتحط في البليستر باك هو السنترويد. No طبعا. No. ده مفيش بليستر باك بتعدي إلا لو فيها سنترويد. Okay. Let's proceed, my friends. Okay. ناخد نفس.
دكتور.
سيجارة.
Sorry. Just quickly. الانتي تي بي او وين تستعملها؟
عز انت يا سلام.
يس.
وانت عراقي برضو؟
انا برضه عراقي.
انت اخو عز؟
لا
يا راجل انت مش عارف ده صوتك ونفس ده، انا فاكرك عز يا جدع. هو انت اللي كنت بتجاوب ولا عز اللي كان بيجاوب في طول السيشن دي؟
عزي.
عز اللي كان بيجاوب.
لا انا كنت بكتب.
ده انت نفس التون. اتكلم كده عز مع سلام.
احكي عراقي يعني؟
طب احكي كده عراقي معلش، ادينا فصل عراقي. عايزين حاجه صعبه بالعراقي احنا ما نفهمهاش وهو يفهمها.
فاصل منوع.
عايز تقول ايه؟
قول اي حاجه صعبه.
لا مش هتفهموا ولا حاجه يعني.
لا قول بس يا عم.
بنحكي عراقي ولا عراقي السهل يعني؟
عراقي من النجع الجواني.
عراقي من من الناس الكرديين. ما هو الكردي عراقي.
جفجفير.
يس.
تكلموا لغه ثانيه خالص يعني.
ده غير
خلاص عراقي ماذا يفتهم علينا؟
تعرف الجمبر؟ جمبر اسمها ايه؟
جمبر ايه؟
اسمها جمبر ولا اسمها ايه؟
هي اللي هي ايه؟
القشطه.
جيمر
جيمر صح. جمبر ايه بس؟
هو مثل الكريم بس ملخبطين.
ملوش حل يا عم انت البتاع ده.
هي مثل الكريم بس ملخبطين بالحروف.
ده لا بس ده بصراحة اختراع يعني. اختراع.
الجيمر مع الكاهي.
اذا تروح تبحث ال دي ال بعد ساعة.
لا هو الجيمر ده اللي انا بقيت باكله كده يا عم. بقيت باكله.
لا خلاص مش ما تاخذوش كده.
هو دسم بصراحة بس يعني مغري.
بس بيجنن.
اوكي.
كل العراقيين كوليسترول عندهم.
بيعمل دايابيتس. الجيمر.
By the way, Dr. Mohamed, he is from the same area that I'm from. I can tell from the way he's speaking. That's why we have the same tone.
From the same region.
هو مصلاوي. انت مصلاوي صح؟
Yes.
من الموصل.
يس الاصل. ايه
اهلا بيك اجدع ناس.
الله يخليك تسلم.
طب برضه ما تكلمتوش كده، ما تديله كده رطمتين كده بالمصلي كده.
رطمتين باي لهجه؟ ما عندنا 100 لهجه احنا دكتور.
يا عم قول اي حاجه احنا هنفهم ان شاء الله.
زين خيري. انت شلون شفت؟
زين شلونكم؟ ايش تعملون؟ شكواكم؟
الحمد لله زينين. انت ما شلونكم؟
ملاح احنا ملاح.
انا يعجبني دكتور محمد زين.
ايه كلش مليح.
طب حلو كفايه كده. هو انا ده لي انت قلت كلمتين في الاول ما فهمتش منهم حاجه، بس بعد كده انت قلت يعني انتوا بتعملوا ايه واخباركم ايه وحاجات كده يعني.
ايوه.
طب
زين.
يلا خلاص.
Let's get back to our business.
Let's get back to the questions.
Yes.
When do you use the anti-TPO? Is this for hypo or?
Okay. What does it mean, the anti-TPO? What does it mean?
I have no idea. بس أنا أشوفها دائما it's one of the screening tool or a diagnostic tool يعني to screen for
Yes, yes, it's antibody for thyroid. Okay? It's the
okay.
antibody for thyroid. So
Mhm.
what's expected here? What's expected if you have antibodies for thyroid hormone, for example?
Mhm. يعني
Is it what it will cause hypo or hyperthyroidism?
it would cause hyper.
Yeah,
Not
right.
hypo.
You have
No,
antibodies for
No,
the
لا
thyroid.
hypo sorry hypo.
hypo.
Yes, because you have antibodies against the thyroid hormone. Okay,
Okay.
so it will distract the thyroid hormone, with eventually will lead to the hypothyroidism. Okay,
Cool. Okay.
that's it. Yes. يلا بينا بقى. Let's go to diabetes. Gamer and diabetes. Okay. What's the effect of gamer on the blood sugar? Okay, we have a case scenario. Let's start by a case scenario, my friends. Okay, to warm up. AG is 45 years old male patient has randomly noticed that his fasting blood glucose reading is 6.5 millimole per liter. He thought that he may be diabetic and came seeing you at the pharmacy for consultation, where you asked him to do an OGT test, oral glucose tolerance test, for which the result revealed at 7.6 millimole per liter. What would you tell him? He might be impaired fasting glucose patient. He might be impaired glucose tolerant patient. He might be diabetic. A and B. Yes, you got the point. You have a patient. Okay, his fasting blood glucose is 6.5, and his random or OGT was 7.6. So is this patient diabetic? Is this patient impaired glucose? Is this patient impaired fasting glucose? By the way, you have the definition in the CTC and you have everything in the CTC as well. And this is the tricks that you are not noticing in the CTC. Okay, so Ziad answered C, then he deleted the answer. What are the answers, my friend? Okay, Rana saying A, Hala A, Rima A, S A B. Yes, fasting is 6.5, OGT is 7.6. Is this patient diabetic or another thing? Might be pre-diabetic. Could be. Summer A, Noha B. Ziad C, Hala A, Rana A, B, 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 A, B, B, D. Summer B. Pre-diabetic and impaired glucose tolerance. Fight B. سارة A. ماشي. طيب عز A. ماشي. طيب هي الإجابات مترددة بين ال A and. Perfect. Okay. What we have here, my friends, we have here two readings. The fasting one, which is 6.5, and we have the random or the OGT, which is 0.06. The definition of IFG, which is impaired fasting glucose patient, when the reading is between how much? we can say how much if we got the reading that we can say this patient is IFG, impaired fasting glucose. 6 over 6?
From
Yeah. Yes, from 6.1 to 6.9. Okay. Yes. Yes, correct. So this patient could be IFG, but let's check the OGT as well. What about the OGT? It's 7.6. The definition, if we can say this patient has impaired glucose tolerance, when the reading is between, as Rima said, 7.8 to 11. Okay. The patient's reading is 7.6. So the patient does not meet the criteria of the IGT or the impaired glucose tolerance. So this patient is impaired fasting glucose and he's not diabetic. Of course, he's not diabetic. Why? Why he's not diabetic? Because of the readings. Correct? So this patient is impaired fasting glucose patient. So he's pre-diabetic, could be a pre-diabetic. Okay, clear, I think. Most of your answers went to A, I think. Okay, this is good. انتوا دايما بتدخلوا في السؤال الأول الله ينور. انت مش عارف ايه اللي بيحصل بعد كده نشوف بقى هنشوف. Let's keep the momentum. Let's keep the momentum as well. Okay, question number 2. Which of the following medications can be used for AG in order to prevent or delay the diabetes in patient with IGT or IFG like him? Is it liraglutide? Is it orlistate? Is it insulin? Is it none of the above? Yes. B. Okay. We got B. We have D. Yes, Noha D. Shayma D. Is Bio. Rana D. Fight D. None of the above. None lifestyle modifications. Okay, so end. Okay, this is a tricky question. Okay, this is a tricky question. Okay. As I thought, most of you will go for B. Okay, which is the wrong answer. It's not correct. The correct answer is D. None of the above. As Faid and no Salam, Rana, Noha, Shayma. Okay. وسمر as well. No, not Summer. في حد تاني. Noha. Yes, no. Okay, so it's D, my friend. Here, if the patient got the patient is pre-diabetic, if he's pre-diabetic or got IGT or IGF, so it's too late to use the medication to prevent the diabetes. Okay, it's too late. You cannot use orlistate, you cannot insulin, you cannot liraglutide, you cannot use the acarbose, even the metformin. Okay, you cannot use it here. Okay, to prevent the diabetes. Okay, no prevention for the diabetes in this stage. It's too late. Okay, what you can do here, lifestyle modification, as Sarah said. Yes, non-pharmacological lifestyle modifications, diet, etc. That's it. This is all you can do here in this stage. But neither the metformin or the liraglutide or the orlistate or any other thing can prevent. Do you know that liraglutide has an impact as well to prevent the prevention of diabetes or delay the incidence of diabetes? Okay, liraglutide. Previously, we were saying MATO. Metformin, A for acarbose, T for thiazidonines, like the rosiglitazine or bioglitazine, الحاجات دي. O for orlistat. Now we have as well liraglutide. Liraglutide as well can prevent or delay the incidence of the diabetes according to some evidence. Okay.
دكتور معلش الماتو ميتفورمين اورستات والتي ثايروزايروزدين ده
سايزوبارد اسمهم ايه هو اللي هي
ما اعرفش انطق اسمهم ملعبك كده.
سايروزينيدين
Now we can make it malto.
مالتو دلوقتي مالتو يس
أيوة.
كانت ماتو دلوقتي بقت مالتو يس كوريكت. ايوه سيادوليدونينز يس يس.
طب يا دكتور معلش حضرتك بتقول دلوقتي انا it is too late لما يكون عندي impaired جلوكوز سواء فاستنج او بوست برنت او 2 hours بوست برنت. اوكي امال امتى استعمل مجموعه المالتو؟
مجموعة مالتو when the patient is at high, like if he's in high risk, like he has a family history, he's overweight, he's cardiovascular, everything, any other thing, or has indication for one of those medications. You can use orlistate or liraglutide for the obesity, for example, correct?
يعني دول الهاي ريسك بيشنت بس.
Yes, for high risk patient, yes, you can use it to prevent or prevent or delay the incidence. There is some evidence for that, okay, but not in pre-diabetic.
لكن لو دخل في البوردر لاين او في البري دايابيتك ما اقدرش استعمله.
Yes, no evidence. We don't have there is no evidence, okay. As long as no evidence, no recommendations. Perfect. So number 3, as it was turned out that AJ is not a diabetic, so at what time interval should AJ be screened for diabetes? Every 6 to 12 months, every 1 to 2 years, every 3 years, every 2 to 4 weeks. How old is he? 45. Oh, let's go. Let's go, my friend. So he's not diabetic.
Doctor, how old is he?
45. And 45 we screen every okay. Mariam A, Sarah A, Rana C, Siba A, Hala A, Noha A, Salam A, Leah B, Sarah C, Shaima A. Most of the answers are A, I think. We have B. Okay. And okay. Okay, so this guy, what are the intervals we use to screen for the diabetes? Okay. First thing we see if the patient is, does the patient have a risk factor or no? Okay, correct. If the patient has a risk factor, what we do, we screen him every how long, in what interval we screen him if there is a risk factor.
every 3 months.
No, مفيش 3 months دي خالص. ما اتخلقتش 3 months دي. From 6 to 12 months, correct. From 6 to 12 months, if there is a risk factor, correct. If there is no risk factor, what we do, it's a question of the age here. If he's above 40, we screen him every 3 years, correct. If he's below 40, no screening needed for diabetes, correct. If there is no risk factor, okay. So if this patient AG has a risk factor or doesn't have a risk factor?
معلش above 40 كل قد ايه؟ every كام؟
above 40 every 3 years. Okay, below 40, no screening needed if there is no risk factor. Okay. Okay, Rima says yes, he has. Yes, he's pre-diabetic, so he has risk factors. Correct. Correct. Bravo. So what we have to do here to screen him every 6 to 12 months. Okay, because he has a risk factor here. Apart from the age. First criteria is about the risk factor. There is a risk factor or no? If yes, every 6 to 12 months. If no, it's a question of the age. Above or below 40. That's it. Okay? This is the criteria, my friend. Is it clear?
Yes, it's clear.
Yes, perfect. So here, every 6 to 12 months. Good, good, good. كده خلصت الكيسة دي، كانت كيسة زغنطوطة كده 3. يلا معلش حظكوا بقى، بس برافو بصراحة. You did well in this station. In this station and in this question, please. Okay.
احنا بتوع
في
الصبح.
ايه بس، ما انتوا ماشيين 100 100 والله اهو. انا بقول برافو عليكم يا دكتورة هبة. ما اقولش حاجة والله. الله ينور، فاجئتوني بصراحة في الديابيتس. اوكي. طب يلا بينا.
يا باشا احنا بتوع السكر.
انتوا بتوع السكر. Which of the following insulins can be used in continuous insulin pump? Insulin glargine, regular, detemer, MPH. B, Rima, Summer, Mariam, Az.
بصراحة في واحد أنا أتصور أنا قريته somewhere else. It's neither of those. Shorter even acting.
Shorter, short acting.
Shortest. Shorter than.
Correct. You can use, yes. So it's in. All of you answered B, which is the right answer, correct. Yes, we can use the short acting or the regular insulin. Okay.
Yes.
We're not using the intermediate or the long acting insulins. Okay. So it's the short acting or the regular insulin. طيب تمام ماشي. انتوا يعني مش عارف ايه الحكاية، بتحلوا صح بصراحة. نمسك الخشب. طب تعالوا لي بقى. تعالوا لي بقى. انتوا الدايابيتس مذاكرينه شكلكم، انتوا الثايرويد كنتوا بتطبشوا فيها شوية. Okay, good. Let's go. Okay, a type 2 diabetic patient taking long-acting insulin plus 3 times rapid-acting insulins has caught influenza-like symptoms due to upper respiratory tract infection. At which situation should you refer him to emergency department? If the patient found ketone body in his urine, the patient has been vomiting for 6 hours, the patient still has hypoglycemia despite consuming carbohydrates, his last 2 glucose readings were 14 and 14.5. Okay. At which situation you have to refer him to emergency? احنا وصلنا فين؟ انا مش عارف انتوا جاوبتوا ايه بصراحة. Yes. We have here okay, B, Salam B, Izz A, C, B, C, B and C, B, C, A, C, B, A, B. Okay. Okay, so this is and that's it. Okay. Do you know the sick days management in the diabetic patients? We have yes, we have two scenarios. Okay. We can refer the patient to the emergency if it's very critical. This is number one. Number two, you have to ask the patient to call his doctor. Okay, this is number two. We have certain situations here and we have another there. Okay. Number one, for emergency department, when can you refer the patient to emergency department?
لما يكون ketoacidosis. Diabetic ketoacidosis.
Yes, dehydration, diabetic ketoacidosis, and persistent hypoglycemia with carbohydrates. This is the situations when you can refer him to the emergency department. When you ask him to call the doctor, when he got ketone bodies in his urine, ketone bodies in his urine doesn't mean diabetic ketoacidosis.
Oh.
Okay? Yes. When he has two consecutive readings of 14 or more, this is number two. If he has been vomiting for 6 hours, and here vomiting doesn't mean that he's dehydrated. Okay, so you have to differentiate between ketone bodies in urine and diabetic ketoacidosis, and between vomiting and dehydration. Okay, that's
مش
it.
فاهم حاجة.
بيفومت
السكر احنا بتوع السكر.
بيفومت فور 6 اور مش هيحصل له ديهايدريشن؟
لا طبعا ممكن ما يحصلوش ديهيدريشن. مين اللي قال لك يحصل له ديهيدريشن؟ الادلت ممكن يحصل له ديهيدريشن في 6 hours.
انا مش عارف، انا بسأل عشان كده.
No my friend.
بس دكتور هو الفوميتنج ليه انا بقول مش فاهم حاجه زي ما بيقول ديفيد vomiting for 6 hours it's a referral point in general.
Referral to what? To emergency or to the doctor?
لا emergent اعتقد.
No my friend. No my friend. No my friend. Emergency if he is dehydrated. Signs of dehydrated due to result from the vomiting. As I said, you have to differentiate between vomiting and dehydration. Okay, if he's vomiting, it doesn't mean that he will get dehydrated. Okay, he may get dehydrated and may not. Okay, it's a risk factor to be for the dehydration. Yes, diarrhea and vomiting, as we know. Okay.
الكيتون بودز اللي في اليورين عادي يعني؟
Yes, ketone bodies with insulin could be corrected. هو راجل عنده ketone bodies ممكن الانسولين بتاعه مش كافي. So خد انسولين يا حبيبي. You will be fine.
انما مش تكون دي كي ايه.
Keep hydrated and take insulin. That's it. But doesn't mean that he has diabetic ketoacidosis. What are the symptoms of diabetic ketoacidosis? What are the symptoms?
symptoms لو على respiration مثلا بيبقى عنده rapid وديب respiration.
Due to the
Fruity smell.
Fruity smell.
نعم.
Okay.
yeah اوكي. ودي بتحصل مع diabetes type 1 يعني mainly مع diabetes type 1.
Yes, correct. This is type 1. And the patient here is what? Patient here is type 2.
هي دي النقطة اللي كنت بفكر فيها. هو هنا ده type 2 فأنا بستبعد الديابيتيك كده. هو ممكن يكون عنده HHS اللي هي الهايبر اسمولاريتي. اوكي لكن
Hyperosmolar diuresis. Hyperosmolar diuresis, you mean? Okay.
yeah.
Okay. So guys, let's repeat it. Okay, let's put things into perspective. Okay, let's repeat it. You have two situations. Okay, to refer to emergency and to refer to the doctor. Okay, when to refer to emergency, 3 cases: when the patient is dehydrated, okay, when the patient is diabetic ketoacidosis, has diabetic ketoacidosis. Number 3, when the patient has persistent hypoglycemia. Okay, those 3 situations are referral to emergency. The other situation, when to call the doctor or advise the doctor, when the patient has 2 readings of glucose above 14 or above. Okay, when the patient is vomiting for 6 hours, when the patient have ketone bodies in his urine, it's positive. Okay, so he has to call the doctor to adjust the insulin dose for the situations. And for the vomiting, he has to advise the doctor to prescribe him any medications, or even the doctor can refer him to emergency if needed. Okay, but for the insulin, for the high glucose reading, and for the ketone bodies, he has to call the doctor, okay, to give him insulin, a higher dose of insulin, or any other thing. Clear?
يبقى الإجابة هنا إيه بقى؟ اللي هو نمبر سي، مش كده؟
Yes, sir. الإجابة is C. Okay?
ماشي.
You got it?
والله
اللي بس بتوع السكر بس ومش عارف ايه. قلت لك تعالى لي بقى.
ما هو السكر خلص في أول، السكر خلص في أول 3 أسئلة.
لسه ده انا في استشانية زي العسل جايه لكم. Okay. It's good, by the way, to know to gather new information and know.
No, this is very good, honestly, because the other stuff we know. You're asking about the very detailed stuff.
Yes, that's it. And this is the question stuff. This is the exam stuff. Okay. Next question. Difference between Lantus. Yeah, sorry, دكتورة ريما. عايزة ايه معلش؟ when to refer to the physician? Yes. When we refer the patient to physician. When the patient found ketone bodies in his urine. This is number 1. Number 2, it's written here. When the patient has vomiting for 6 hours. The patient has been vomiting for 6 hours. Okay. Number 3, when the patient has reading of 14 millimole per liter for 2 readings. For 2 readings, not only 1 reading, for 2 readings. Okay. This is according to the guidelines, by the way. Okay. Yes. ماشي. يلا بينا. Difference between Lantus and Toujeo. Lantus, as you know, Lantus is insulin. Both are insulin glargine. 100 units per milli for Lantus and 300 units per milli for Toujeo. Okay. Which one is correct? Okay. Toujeo has lower risk of hypoglycemia than Lantus. Lantus has higher glucose lowering effect than Toujeo. Toujeo has longer duration of action than Lantus. Lantus seems more effective than Toujeo in insulin-resistant patients. We are seeking here the incorrect answer, not the correct. Incorrect answer. Okay, so we have 3 correct answers and 1 incorrect. Which one? Aiz is saying it's number C. ناخد رأي حد تاني من أصدقاء البرنامج. سارة دي. We have another Sarah with D. سارة دي. ديفيد دي كمان. ماشي يا عم ديفيد.
دكتور هو انا I have no clue هي ليه دي، بس انا حاساها دي عشان بس ايه يعني لو just in case ان الناس بتكمل ورايا دي فيعني لا انا ما اعرفش
والله انا
يعني
واثق ان هو بيكمل وراكي هو ديفيد. بصراحه
يعني
ديفيد كل سنه
انا
بيحط
برضو
عينه كده على
حبيت
حد
انوه يعني.
وبيجاوب زيه. بس اللي عاجبني في ديفيد اللي هو ما بيمشيش ورا ارميات، خلاص بطل يمشي ورا ارمية في الاجابات. ودي جود ساين يا ديفيد يعني.
لانه صاحبي.
دي جود ساين. ماشي انا بهزر معاك يا ديفيد. عارف يا باشا والله بس بهزر معاك. Okay, so we have A, B. Okay, C. Let's start from عز. Okay, عز C. Sarah D. David D. Hiba C. Rima B. B. Okay, so we have A's and B's, correct? Okay, we are looking here for the incorrect answer, which is D. The D is wrong. Toujeo has lower risk of hypoglycemia than Lantus. Correct. Lantus has higher glucose lowering effect than Toujeo. Correct. Toujeo may has longer duration of action than Lantus. Correct. Lantus seems to be more effective than Toujeo. This is what we call تحشيشة. دي تحشيشة كده من عندي. Number D. There's no evidence about that. Okay? Yes. Yeah, as I told you, as we are looking for the incorrect answer.
ما هو انا خلاص اخترت ورحت بمكان تاني اصلا. لا انا هي متاكد منها يعني، فانا شفتها سي خلاص هي السي متاكد منها يعني بيشتغل مده اطول.
Yes, correct. C is correct. Yes.
Yeah,
so, and by the way, Lantus has, yes, there is some evidence that Lantus has higher glucose lowering effect than Toujeo. Okay, Toujeo has lower risk of hypoglycemia. This is correct as well.
Yeah,
okay?
That's correct.
So this is a difference between the two medications. They are very important, by the way. This medication, these informations are very important.
I've never heard of the B, to be honest, بس أنا أعرف ال A was C for sure, بس ال C متأكد منها for sure, so I just went with C. I didn't know that which one is the incorrect.
Yes. Okay. Good.
معلش سؤال باي ذا واي. هو انا عارف ان الباي افيلابيلتي، معلش هو يمكن خارج السؤال بس مرتبط بالقصه.
Can you say it in English, Armia?
Okay. Can I ask about the bioavailability?
Rashmi still here. She left, huh? She left. Okay. تعبت رشمي ومشت. Okay. قول يا باشا.
Can the Toujeo, the bioavailability of the Toujeo, it is higher than the Lantus? Yes or no?
The bioavailability of Toujeo higher than Lantus? No, I don't know.
Or it is the same bioavailability?
I don't know. Honestly speaking, I don't know. Okay. It's less.
Right. It's less.
We have Mariam says it's less, and Rima says yes, it's more, 15% more.
Okay. Now if you convert from Toujeo to Lantus, unit by unit.
When you convert.
Okay, a patient taking the 10 unit HS from Lantus. Now we have no Lantus, we have Toujeo. We give it 10 unit Toujeo HS also, unit by unit.
From Lantus to Toujeo. Okay, what
and
we
from Toujeo to Lantus.
يا عم انت عايز ايه؟ انت عايز توجيو للانتوس ولا لانتوس لتوجيو؟
مريض بياخد 10 وحدات من اللانتوس بالليل.
Okay, you want to convert him to Toujeo, correct?
اديله 10 Toujeo برضه.
Okay, from Lantus to Toujeo, we give the same dose. From Toujeo to Lantus, what we do?
Decrease 20%.
Yes. الله يبارك لك.
تاني بقى كده معلش ربنا يبارك لكم انتوا من Lantus to Toujeo اعمل ايه؟
From Lantus to Toujeo, we give the same dose.
The same unit. Okay.
The same, yes, the same units.
Yeah.
To be adjusted according to the glycemia. Huh?
ماشي. من التوجيو بقى
From
لللانتوس.
Toji to Lantus or NPH, we decrease by from 15, I think, to 20%. Okay.
مم. طب لو احنا بقى من التوجيو لللانتوس بنعمل ديكريز ب 50%، ده معناه ان البايو افيلابيلتي بتاع.
والنعمة ما أعرف، وغلاوتك عندي ما
طب
أعرف.
خلاص ماشي
ما ما تخلينيش
أصل-
أعمل assumptions كده.
لا
يعني
لا
أنا
لا.
ما أعرفش.
ماشي.
Okay, my friend.
اوكي
Case scenario. I اللي عايز يهرب يهرب. عايز يهرب دلوقتي يهرب. Okay. Case scenario. Let's go. إن شاء الله سهلة. إن شاء الله سهلة يا شباب. You can do it. Okay. JC is 76 years old, male patient. Has been recently diagnosed with medication-induced diabetes due to chronic heart therapy. Heart therapy. You know the heart therapy? Do you know the heart therapy? For more than 15 years. Okay? It's not heart, it's heart.
What's the heart therapy?
A highly active antiretrovirus therapy, a retroviral therapy, which is for the HIV.
Okay.
His current medication profile includes, this is the heart, بياخد TVK مع Truvada, Rivastigmine transdermal patch, Memantine 10 mg, aspirin 80, metoprolol 25, omeprazole 20. His recent A1C was 9.2, fasting blood sugar 9, postprandial sugar 12, medical condition HIV, Alzheimer, blood pressure, history of GIT ulcer. Okay? This is the history. Fine. Take all the information you need from here and we will proceed. 76 years old male patient, HIV, diagnosed with medication-induced diabetes. Okay, so let's go. Question number 1. After being diagnosed with diabetes, his daughter shows up at your pharmacy telling she doesn't believe that her father would have diabetes because during the last 2 days and on the same day her father did the lab work requested by the physician, his average glucose reading at home were between 6.5 to 7, and for the fasting, and for the random it was 9 to 10. Okay, so the readings here at home are totally different from the one performed in the lab. Okay, you got the difference? Okay, what would be your advice here? Tell her to discuss that with his doctor and ask her to repeat the self-monitoring blood glucose testing reading. Advise her to check the accuracy of her blood glucose meter. Tell her that repeated normal fasting blood glucose and postprandial readings do not mean that her father is not diabetic, as A1C is the most important. The advice here not to worry and reassure her that her father's doctor will definitely repeat A1C in 3 months. اوكي جو اهيد. عايزين شوية انصارات حلوة كده، شوية عناصر حلوين. نهى استفتحت معانا كده بي. اوكي عز سي، سلام بي، وزياد سي، وشيماء بي، وسمر سي، ومريم سي، هبة سي، ورانا بي تاني بترجعنا والله للبي، وليا رجعتنا للبي، وديفيد بيقول لأ مش عارفين ليه. لأ هي ديفيد مالك؟ يا ديفيد بي.
ده الكيبورد كده على العربي، معلش سوري.
هتيجي جنبك يا ابني.
لا لا هو بي.
بي. بي اوكي. Okay, so we have it's okay. The answers are confined to B and C. Noha B, Izz C, Salam B, C, B, C, B, C. لا لا C, C. Okay. So I think we have more C's than P's, correct? We have more C's, correct? Okay. So حد نفسه يقول حاجة تاني؟ Let's end. Okay. C's okay. Wrong. This is wrong. It's not correct. Okay. Okay. So have you noticed that there is a huge discrepancy between the lab work and the home readings, correct? Okay. So there should be something wrong here. Okay. The most accurate, is it the lab work or the home reading? The lab testing or the home testing?
The lab.
Yes, okay. So here we have the lab. The lab says it's 9 and 12, correct? 9 and 12. While the lady says it's 6 and 9, which is there is more than 20 or 30% discrepancy between the readings. This means the glucometer that she has at home is not working. According to the CTC, if the reading is within 15%, it should be fine. If the difference between the readings is more than 15%, the accuracy of the blood work of the glucometer should be verified. Okay? So here we should check the accuracy of her blood glucose meter.
دكتور انا اخترت سي صحيح، بس انا لانه هي مكتوب في نقطه داله انه هي غلط. لان it says normal. It's not normal. The fasting is 6.5 to 7. This is, you can exclude it already. So I chose C, but I could exclude the C. I could exclude the D because advised not to worry and reassuring that her father's doctor will definitely. This is like ignoring the patient. No, this is
yes.
So
yes.
A, tell her to discuss that with doctor and ask her to repeat, like, why is this wrong? Like, second one, we made an assumption that accuracy is wrong, but based on what you said, if more than 15%.
Okay, because she yes, it's been like 2 or 3 days that she's repeating the readings. Okay, she's repeating.
Maybe she's on a diet. She's not eating enough. Like, yeah.
She's in a diet, maybe.
Like she's not eating as much.
This will not change anything, guys. Here, for here, it's not, because she will use the same machine, and we will use the same patient to get the same. She will get the same result. Okay, it's been like 2 or 3 days. She's measuring the blood sugar, and it gives the same reading. Okay, so here there is something wrong. There is something wrong with the machine. The most important is the day of the test, when the patient went to the lab work, okay, and when the patient got the reading at home on the same day. This is the most important because it's written here. And on the same day, her father did the lab work. If there is a discrepancy of 15% or more, so the machine is not working well. Why would you ask her to repeat the reading? You will get the same result.
Mm.
Okay, so
Yeah.
this will not solve the issue here. You have a standard, you have the gold standard test, which is the lab work. The lab test, you have the result, that's it. This is the standard, this is the rule. Okay, if she's skeptic or she's not pretty sure of that her father has diabetes, she can repeat the test, no problem, not at home, but in the lab if she wants, or ask the doctor to make another lab work. Okay, but if repeating the test will not change anything, you will get the same result. Once again, this is not an OSCE station. You have the information. Okay, you have a letter of information. You have to deal with the situation. Okay, if you are in the OSCE station, you can ask and you can gather information and make the assessment, etc. As you know. Perfect.
دكتور هو في نقطة تاني هو في نقطة تاني. أنا ما أقدرش هنا في الكيس دي عموما يعني أعتمد على ال A1C. ليه؟ عشان الأنتي ريتروفايرالز اللي هو بياخدها بتعمل ديكريز لل A1C. الناس اللي بتاخد الهارت ثيرابي ما أقدرش أعتمد على ال A1C في تشخيص أو متابعة حتى الديابيتس عشان بيعمل ديكريز لل A1C.
Decrease or increase؟
لا، في الانتي ريتروفيروس بيعمل ديكريز. I'm 100% sure.
اوكي بيرفكت.
فالاجابات بتاعت الاي 1 سي يعني حضرتك لما حطيت الاجابات ده عشان زميلنا اللي كان بيتكلم عز، انا الاجابتين بتوع سي ودي انا ما شفتهمش اساسا. ليه؟ عشان مذكور فيهم الاي 1 سي، يبقى انا ممكن احط اي او بي. هي دي النقطه.
Yes. Okay. Thank you, Army.
Thank you, Rich.
Hera, what do you want? Again, which part? When do we check the accuracy of the blood glucose meter? Yes, when there is a difference or discrepancy of 15% or more between the lab work, the lab result, and the home result. Okay, 15%. Okay, question number 2. JC's daughter is still worried about her father and herself, that she could be at risk of having diabetes at some point of her life. Given the information that she is 37 years old and taking only oral combined contraceptives and no other medical conditions, what would be your advice? She's not among the risk group and no screening is currently recommended to her. She should go screening test within the next she should go screening test within the next 3 years when she turns 40. A screening test is promptly recommended. She should undergo screening test every 6 to 12 months. Okay. Sarah Abdullah A. Mariam B. Rima B. Hiba D. Ziyad B. Leah B. David D. Hera D. Rana A. طيب حد يدينا إجابة تانية؟ سلام ابن الموصل A. سمر A. طيب كفاية كده خلاص. كفاية عشان ما تلخبطوش اكتر من كده. بهزر معاكم طبعا.
دكتور أنا غيرت رأيي.
انت مين؟
أنا سارة.
غيرت رايك في ايه؟ انت كنت قايله ايه؟
كنت قايلة إيه بس خليها دي.
اي
لا ما غيرش
انا
رأيي.
لسه والله كنت لسه هقول انا عاجبني اجابات ساره عبد الله.
لا ما أعرفش. أصل بصيت في CDC لقيت مكتوب إن يعني من ضمن الريسك فاكتورز first degree relative with type 2 diabetes mellitus، فهي كده تبقى في السكند
And
group.
here is the trick my friend. Here is the trick my friend. Okay, you got the trick. انت كده بقى انت كده بصي بقى، هي دي الحته اللي انا لعبت لكم عليها من الاخر كده. Okay. What is the answer of previous question? What was the answer here? Advice here, yes, B. Advice here to check the accuracy. Yes, advice here to check the accuracy. Okay. Okay, guys. Okay. Let's. Where the? Yes, this is a question. What is our question? Yes, here it is. Okay, the right answer here is A. يا سارة يا عبد الله. The right answer is A. Okay. Why it's A? The lady is 37 years old, correct? So she's under 40. She's below 40 years old. What about the risk factor? Does she have any risk factor? She has combined oral contraception, which is not a risk factor. No other medical conditions. What about her father? Okay, her father. What was the diagnosis? Is it type 2 diabetes mellitus or medication-induced diabetes because of the medication?
Oh,
The heart. One of the side effects of the heart therapy
yes.
is to get to increase the blood glucose and make diabetes. Okay.
I didn't notice that.
Okay, يا زملاتي. So here is the trick. Okay, so this is medication-induced diabetes. Moreover, the patient is 76 years old. He only developed diabetes at the age of 76 years old. Okay, so definitely it's age-related or medication-related or any other thing. It's not like a genetic diabetes. It's not like hereditary diabetes. Okay, so by no means this could represent a risk factor to the lady. This is not a risk factor because the patient is taking medication for 15 years. Okay, and he's very aged one. He's 76 years old. You got my point. You got the point here. So you have to understand the situation as well. B, she should go screening test within the next 3 years when she turns 40. Yes, when she turns 40, yes, she can. Yes, this could be fine as well. Makes sense. Yes, when she above 30, yes, she has to go to make the test. 40, excuse me, not 30. Yeah, 40. As we say, the age we have. The first thing to decide when to go for screening, the risk factor. No risk factor, no screening. Excuse me. If there is a risk factor, screening every 6 to 7. No risk factor, it's about the age. 40 and above, every 3 years. Under 40, no screening needed. Okay. Okay, but for now, there is no screening needed, correct? So A is correct. B as well, she should go screening test within the next, within the next 3 years when she turns in. I think, yes. لما تبقى عندها 40 سنة ماشي. Yes. B we can say there is a part in B which is correct when she turns 40 years old. Okay.
دكتور معلش ممكن تقول لنا الاعمار تاني لو سمحت؟
عمر ايه يا روحي؟
ربنا يخليك يا رب. اللي حضرتك لسه قايلها دلوقتي اللي هو مش عارف فوق ال 40 ماشي كل 3
تاني
سنين.
انا قلتهم قبل كده ارميا كتير، من
معلش يا
شويه
باشا،
قلتهم تاني.
انا عارف ان فوق ال 40 كل 3 شهور، كل 3
3
سنين.
سنين 3 سنين.
اوكي
اوكي اوكي
اقل من ال 40.
no screening needed if there is no risk factor. بص يا ارميا، first thing to check is the risk factor.
كويس.
There is a risk factor or no? If yes, there is a risk factor, screening every 6 to 12 months.
مظبوط.
Okay. No risk factor, your
اشوف
snack,
العمر.
yes, it's about the age. Below 40, no screening needed. Above 40, every 3 years, if there is no risk factor. Okay.
تمام تمام ميرسي.
That's it. Okay. Next question. Which of the following functions should not be checked for JC if not measured in the past 1 year? Okay, if she didn't do it for JC, yes. Which one we don't need to do in this patient? Okay. Yes, يا سارة تمام الله ينور عليك. Okay. Do we need to check the fasting lipid profile, liver function, urine to create ratio, serum thyroid stimulating hormone? Which one we don't need? البنت ولا الأب؟ لا الجي سي ده الأب. JC is the father, okay? Is the father. Okay? Which one we don't need to measure here? Fasting lipid, liver, urine, thyroid. يلا بينا. وهلا بتستفتح معانا الإجابات برقم دي. سارة بي أوكي. السؤال مش واضح. I clarified it. Which test you don't need to measure for now? Which test you don't need to measure? سيبا D, ريما A, David A, Rana D. Can we see the case? Yes, here you go. Okay. Salam D. Okay. D A D D D D D A. Okay, we have like it's like an balance between D and A's. Correct? Okay, but D is end. Okay. Okay, perfect. D is correct. Okay. Here we have which one we don't need to measure. Fasting lipid profile. Yes, we have to measure fasting lipid profile. Why? Because the patient is taking heart therapy. Heart therapy can cause as well dyslipidemia or hypercholesteremia. Okay, triglyceride as well, hypertriglyceridemia, I think, and cholesteremia in some patients. Okay, liver function test. Yes, we can do because the patient is taking as well the medication, the heart medication. Urine albumin. Yes, because he's diabetic now, and he has to check the ACR, the albumin to create ratio. Serum thyroid, no need to measure it. We in some patients we need to measure the serum thyroid in type 1 diabetes patients. in type 1 diabetes, we can measure the TSH hormone. Okay. Here. But lipid profile, we do it when patient fasting. What's the problem? What's the problem? Yes.
So can you please just say ASC again, urine albumin to creatinine ratio? We did it for what?
For kidney.
For
Kidney.
what? Yeah. For kidney. Yeah, I know. For which, like, is that because she's diabetic?
Yes, because she's diabetic. Yes.
Okay.
Okay.
Doctor, can you remind us العلاقة ما بين الثايرويد والdiabetes? I can't remember actually.
What do you mean?
Like why do
If the patient is hypothyroidic, has hypothyroidism, will he get a higher or lower risk of diabetes?
has hypo?
Hypo, yes. If he's yes, he suffers from hypothyroidism. He will be at higher or greater risk of diabetes.
I think higher.
Yes, he will be at higher risk to get diabetes if he's hypothyroid. Okay, so because TSH can, excuse me, the T4 or the T4 ليه علاقة بالسكر. هو بيساعد على حرق السكر في الدم. اوكي، فلما بينقص ال T3 أو T4 في الدم، ده بيساعد ان السكر ما بيحصلوش كاتابوليزم او ما بيحصلوش يعني السكر تبقى زيه زي الليبيد. اوكي، مع برضه بيبقى عنده ريسك اعلى ان هو يحصل له ديسليبيديميا. اوكي، لو هو برضه هايبوثايروديك، لو هو عنده هايبوثايروديزم بيبقى عنده مشكلة، في ممكن يحصل له جلوكوز انتوليرانس، ممكن يحصل له ديسليبيديميا as well. اوكي بس فدي من الحاجات اللي برضه you should consider it. But here in diabetic patient, we don't go for the TSH unless the patient is type 1. Because I think because of the autoimmune relationship or between the type 1 and the thyroid, between the type 1 and the type 1 بيبقى عندهم مشكلة في الأوتوميون. اوكي، فبرضه بيربطوها شوية بالثيرويد، فمن ضمن الحاجات ان هم بيقيسوا الثيرويد مع البتاع دي. How many questions left? اوكي، انتوا عايزين تناموا صح؟ طب ما السهرة حلوة. طب خلاص قربنا نخلص، احنا خلاص بنشطب بقى.
احنا هنتسحر مع بعض كده.
نتسحر مع بعض. اوكي، نو بروبلم يا نوع، جو هات. اللي عايز يتفضل يا شباب اتفضل. انتوا عايزين تكملوا ولا نكتفي؟ كملوا انتوا.
يا باشا نكمل يا ريت يعني.
ماشي يا عم. ماشي يا عم.
دكتور يا ريت تكمل.
طب يلا بينا. ماشي. Question number 4. What factor may not come into consideration while choosing the suitable anti-hyperglycemic medication to JC? What factor may not come into consideration while choosing the suitable anti-hyperglycemic medication? Is it the weight, kidney function, age, risk of hypoglycemia? We have some criteria or some determinants that we can consider before starting an anti-hyperglycemic medication. Correct? ايه ده كله؟ ايه السهات دي كلها؟ اشمعنى انت يا شيماء بيا؟ شيماء سي. She turned to see. Okay, she switched. See. يلا بالمرة. Okay. Rana saying A. يا رنا حرام عليك يا رنا، مش إجاباتك دي. أكيد مش أنت اللي على الكيبورد. أرميا، حتى أرميا بيجاوب سي يا شباب. ماشي. Okay, that's it. It's enough, my friends. Okay, end. Okay, the answer is C. We have how many criteria for which we can determine which anti-hyperglycemic we should start? You know what factors we consider or what determinants? Any idea? Weight, cost, kidney, cardiovascular, yes, yes. Kidney function, correct. Exactly, yes. Weight, kidney function, risk of hypoglycemia, of course, the cardiovascular disease, and the cost, the insurance coverage. And some, yes, some medications are not covered by the insurance. That's it. But the age is not a factor here. Okay. So we can consider weight. Weight is very important. If the patient needs something that helps him to lose weight or no, or cause some anti-hyperglycemic as well may cause weight gain. Okay, kidney function, age, and risk of hypoglycemia. Of course, risk of hypoglycemia is very important, especially in the elderly. Okay, so age is not really a determinant here. Okay, so it's clear, I think. Question number 5. The best initial therapeutic approach to JC in order to reach normoglycemia is education and non-pharmacological measures, initiate treatment with metformin, initiate insulin therapy, initiate GLP agonist like dulaglutide as a monotherapy or in combination with metformin or insulin. Okay, what do you think?
معلش ينفع نرجع بس كده تاني دقيقة واحدة؟
ماشي يا عم. عشان انت ابن المقاطعة بس. اتفضل يا ريس. Okay, we have Mariam says B, while all other colleagues are saying C.
So can we go back to the question?
والله. خلاص يا ديفيد. Here it is. C is initiate insulin therapy. Yes, initiate. This is, and we have B. The only B we have was Mariam, and we have as A, education non-pharmacological measures. Sarah B. Okay. What is the A1C, guys? It's 9.2, correct?
Yes,
Okay.
but
This
he
says
doesn't have any symptoms or decompensation.
Has Alzheimer is the key point. The key point is he has Alzheimer.
yes. Okay. Not high A1C. 9.2 is not high A1C يا دكتورة هبة. والله حرام عليك. A1C is 9.2, I think. Correct?
Yes.
This is not high. How come? Okay, so أنا برضو أنتوا لخبطتوني. Okay. مريم B. Leah C, B, A, B. Okay, we got C's. Yes, most of the answers were going to C. Okay, should we start the insulin therapy with this patient? Yes or no? Huh? Yes or no? Quickly. Yes. Yes. Wrong. 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 This is wrong. Okay? Why is this wrong? Can you rationalize it?
احنا ما جربناش حاجه بناخد انسولين ليه يعني؟ مش عارف انا. وهو فوق التارجت باقل من 1.5 اصلا.
What's his target?
His target is up to 8.5 يمكن لما 7 ولا
Yes,
7
correct.
point something up to 1.5
Correct.
up to 8.5 sorry.
Correct. This guy's target is not 7. Okay. This guy's target is not 7. Why is not 7? Because he got dementia. He's Alzheimer patient and he's elderly. Correct. So we cannot set the target.
Yeah, doctor, just I had a question. And the CTC it says frail elderly. So does that have to be any elderly who is above 65 or just the frail ones that have dementia and let's say Alzheimer? I was sure of this answer because he has Alzheimer and he's above he's elderly.
If he has Alzheimer, not
Only
every,
if he has
not every,
Alzheimer.
yes, not every, no,
Elderly.
if he's very sensible or sensitive to hypoglycemia, you can start with other medications other than the insulin. Okay?
Or he can't keep up with his, he's not very sure, like Alzheimer, he forgets.
Exactly, but for this patient, he got Alzheimer. Okay, it's clear. So we cannot set the target at 7. Okay, it's 8.5. This is the target. And his A1C is above the target by less than 1.5. So insulin is not the first choice here. Okay, Aiz went for education and non-pharmacological measure. Can you educate this patient and give him non-pharmacological measures?
Oh,
yes.
Metformin.
Yes, he's 76 years old and he got Alzheimer in HIV.
But we can't assume that we can't educate him, doctor, as well. We don't know his severity of his Alzheimer.
No, my friend, he's taking the patch and he's taking Memantine. Memantine at what stage we started?
Yeah, I know, severe. Like when there is no
severe and moderate. Yes, it's moderate severe. So this guy is deteriorating.
Yes.
Okay.
إذا بيجيبوا أسئلة زي اللي بتجيبها دي إن شاء الله وألف مبروك.
على فكرة والله ساعات بيجيبوا حاجات كده عشان تبقى عارف يعني بيجيب لك تكات كده خفية.
بس هي دي الأسئلة يعني لما تلقط like I يعني I found one key point and then I went with the with one answer which I was thinking is right.
Yeah, you have to.
But then there's another point that you can't educate.
Yes, Metformin, my friend. You cannot educate him, and you cannot counsel him on non-pharmacological measures. What would you say to him? Go to exercise. Go to exercise, and
he's gonna forget. Yeah.
Okay. Initiate treatment with Metformin, and if you notice during the case here, his daughter who's coming and ask. It's not him. Okay, his daughter. Correct? Have you remarked that? It's not the patient. So this
we have to look the case. We have to look the actual case to answer it. We have to look the scenario, like we're in actual pharmacy.
Correct. يلا بينا. Okay, so this is clear. So the answer here would be initiate treatment with Metformin. Okay, sorry. Yes, I forget dementia والله. Yes. يعني هو لو عندوش الزهايمر ممكن أبدأ بنون فارم. No, if he's concentrating, yes, you can.
يعني دكتور هو دلوقتي التارجت بتاعه 8.5 وهو دلوقتي 9.2 فهو أقل من 1.5 فمش هنبتدي الانسولين صح؟
Yes, my friend. You cannot go for education and non-farm for this patient, correct?
Oh yes.
But so what you have here? What you have the Metformin. That's it. And why you cannot go for Doula glutide? Why this couldn't be an answer? اللي يجيبها بقى يبقى بص بقى هديله اللابتوب اللي انا شغال عليه.
طلع لنا الكيس دكتور اذا سمحت.
ده دكتور بيشتغل على البوست برانديال ما بيشتغلش على الفاستنج.
يعني
الدولا جلوتايد بيتاخد وانس بير ويك.
ماشي، عايز ايه طيب؟
ماليش دعوه هو كده. هو بيتاخد وانس بير ويك وهو عنده الزهايمر.
يعني انا ممكن ابتدي الدولا جلوتايد لو هو كان على اللانتوس مثلا،
ريسك اوف فولز دكتور عنده كثير،
او ماشي مثلا على الميتفورمين.
هايبوتنشن يصير ممكن، مو
هايبوتنشن؟
لا ده مع لحظه لا.
CVS complication? No, my friend. Dulaglutide has a positive,
لا هذا
has a
ثاني.
protective effect.
Yeah.
Dulaglutide is the same like liraglutide and cabazine
Yeah,
and
just
okay.
هو حسب السكيم يا
Let's
جماعه،
see
ما
what
انا
else
ببدا
take.
حسب السكيم. طالما هو التارجت A1C بتاعي يعني وزين يعني مش اعلى، خلاص يبقى
لا
انا
هي
ببدا
مش ارميا، هو في سايد افكت بيتضارب مع واحد فيهم بس انا مش لاقيه.
ايوه، الله يفتح عليك يا جدع، الله يفتح عليك يا اخي بقى. انت تفتح الباب، فاكر انت لما قلت لك انا كذا مره اقول لك انت بتفتح الباب وبعد كده بتخيش انت وتسيب
انا
غيرك.
عارف انا عارف
عملتها
نفسي.
في الاوسكي برضه في كذا ستيشن، تعمل الحركه دي.
مم.
تحط ايدك على الجرح بس ما تجاوبش صح.
يعني ممكن، بس في شيء يعني ماينر فيري ماينر، اوميبرازول اللي هو ممكن يزيد الانفكشن، وهذا يزيد الانفكشن.
ليا بدأت كده، شكلها كده هتجيبها ليا.
بس صعب كثير.
ليا شكلها كده هتجيبها.
قصدك البنكرياتايتس او
اوكي my friend, this حد هيقول حاجة ولا اقول انا should I go for the answer؟
هي بتاخد اوميبرازول وممكن يحصل لها نوزيا وفوميتنج.
Yes. This guy has GIT ulcer, okay? Has a history of GIT ulcer. This is number one. Number two, he's taken rivastigmine and memantine and etc. Rivastigmine has a severe side effect on GIT and cause weight loss. So rivastigmine, all ACE inhibitors cause weight loss, and dulaglutide, the same thing, will cause weight loss and GIT problem. The most common GIT, the most common side effect with the GLP-1s is the GIT side effect. And he's already taken rivastigmine, which has a significant GIT effect. Moreover, the weight loss side effect, the same thing like dulaglutide. Okay? So you will cause excessive weight loss, you will cause excessive GIT side effects for this patient. Okay? So in this case, dulaglutide would not be a good answer, would not be a good choice. Like Aziz said, yes, because of the side effect. شفت يا عم عز؟ يعني انت برضه حرشتها كده. It's because of the side
انا
effect.
دكتور دايما بروح على الهاي دايما انا عارف نفسي.
تريزيجيه، وانا مسميك تريزيجيه يا عم بتاع الكوره بتاع مصر، يقعد يرقص الفريق
بروح
كله،
على الكل
يرقص
وكل
الملعب
انا عارف
ويشوط الكوره بره.
لاعب منتخب مصر بعرف. انا عارف.
بالظبط كده. Perfect. Okay. So this is for your knowledge. Okay. Mariam is asking, but can we start with it if not GIT problem? Yes. If there is no other overlapping side effects, yes, you can start with it. If the patient, if there is a benefit like cardiovascular benefit, weight gain or something like that, even apart from that, yes, GLP-1s, you can start with them as a monotherapy or in combination with metformin. Okay. Okay, يلا بينا السؤال السادس. After 4 months, the treating physician has decided to initiate insulin therapy to JC due to uncontrolled diabetes after trial of oral antihyperglycemics. His last A1C reading is 9. What would be your recommendation? Oh, yes. So the doctor decided to initiate insulin therapy to this patient after 4 months from metformin, of course. It's been like 4 months now. He's taken metformin, but the A1C is not moving down. So the recommendation would be intensive insulin therapy with basal and bolus insulin is the best recommended, or only basal insulin as initial therapy is recommended, or only bolus insulin as initial therapy is recommended. Insulin therapy is not recommended for JC. ما تجاوبوش اللي في بالي. محدش يجاوب اللي في بالي. لا ما اعرفش، الله اعلم. انت بقى بص معاكي كل المعلومات يا دكتورة ريما. شغالي بقى كده المخيخ وطلعي لنا الإجابة. D or B or C or A. اوكي دي اي جاوبت اللي في بالي. ليه كده يا شيماء؟ انت وسيبة وزياد وريما. اوكي اوكي يلا بينا. end. Okay, perfect. So here D is like a trap. Okay, like a trap for you, like an entrapment or something. So D is not correct. Insulin therapy, yes, we can start insulin therapy in this patient, especially after 4 months. If the A1C is not going down, so why not to start insulin therapy? Okay, you don't have the choice. Okay, but it's about the technique or the approach you will have, you will choose. Okay, usually we start both bolus or basal or pulse together. We start with which one?
We start with basal.
Basal.
In type 2.
Yes, we start with basal. Correct. So we'll start with basal. Only basal insulin as the initial therapy is recommended. That's it. Okay. Do you know how to adjust the dose or titrate the insulin dose?
We start with 5 to 10 IU, then increase 2 to 3 units until we reach fasting blood glucose 7.
Every how many days?
Every 2 to 3 days.
Yes, correct. This is correct. I know what I'm believing. Okay, perfect. So basal insulin is the correct answer. So the answer here is B. Intensive, no. Bolus, no. Therapy, we can give insulin therapy. Perfect. Question number 7. Yes, it's like not an MCQ question. It's.
May I ask you, sorry, a question before I forget? Sorry. I know it's not the time. So دكتور أنا امتحاني هو في امتحاني في شهر الخامس يعني، وأنا خلص يعني تقريبا براجع. أنا براجع على الشابترات اللي عندك، اللي نزلتها الصوتية كلها. دكتور بس أنا عايز أسألك الإيش أنت do you recommend anything on top of those lectures?
Are you studying the CTC?
For now, I study the CTC, but not all the subjects. But for now, I'm just following with you. يعني أنت اللي بتدرسه تقريبا مثل CTC. يعني.
No, my friend. I'm always saying, if you are not studying the CTC, this is the lecture and session we do are not sufficient. The CTC is the main. No, there is no course, no teacher, no lecture, no session, no other thing would suffice than the CTC.
صحيح. Okay.
مفيش حاجة، اوعى تذاكر حاجة ولا تسمع كلام حد غير السي تي سي. انا بقول لك عشان بس انا بصحصح لك دماغك تركز على ايه في السي تي سي، او اديك معلومات جديده مثلا، لان في حاجات انا بجيبها هنا من اب تو ديت، وحاجات بجيبها من المونوجرافز انت ممكن ما بتاخدش بالك منها وانت بتذاكر.
اوكي. اوكي دكتور، اوكي شكرا.
بس لكن ما تركزش. يعني انا الكلام ده قلته حتى في السيشنز الصوتيه، بقول دايما ذاكروا السي تي سي. السؤال ده اتسال كذا مره يا عز.
أوكي.
لازم تذاكر السي تي سي. نصيحتي لو انت مش مذاكر السي تي سي كويس ما تضيعش اتمت. لو انت اوريدي دخلت امتحان قبل كده وضيعت محاولات فما تضيعش اتمت.
اوكي دكتور.
اوكي. الام سي كيو محاولاته غاليه، اغلى من الاوسكي عشان تبقى عارف.
اوكي.
الاوسكي سهل، انا دايما بقول الاوسكي اسهل من الام سي كيو بكتير. الام سي كيو لو ضيعت فرصه لازم تركز 200 مره بعد كده.
مهم.
اوكي. الام سي كيو ملوش ماسكه، الاوسكي تعرف تمسكه. الاوسكي براكتس، هتجاوب، هتمشي على سكيم، you will get it، هتعدي، you will pass.
نعم.
اوكي. but the MCQ no, you cannot predict.
انا درست على التي سي بس كمراجعه انا اصلا.
لازم تراجع عليها كويس، لازم كويس. اوكي.
مهم. اوكي.
سي تي سي لازم تراجع كويس وتسمع طبعا السيشنز، تحل اسئله طبعا، تمام، ما فيش مشكله.
اوكي.
انا بالاسئله دي انا اي دو، يعني مش عشان انا اللي عاملها بس، لا يعني اعتقد ان هي بنسبه كبيره بتبقى فيها تكات مهمه في الامتحان.
ايوه صحيح.
احنا الحمد لله في الحاجات اللي
يعني
عملناها
انا
في
رجعت
الأوسكي،
السي
خد
تي
بالك.
سي بعدك، يعني اغلب الاشياء انت بتقولها، يعني ما فيش اشياء بتعبر كتير بالمحاضره يعني.
يس اكزاكتلي.
انا عشان كده بقول لك يعني انه هي بتكفي انه after you like for a review.
ما اقدرش اقول لك تكفي طبعا. انا اصل أنا مش ريفرنس، انا كلامي مش ريفرنس. الريفرنس
ايوه
هو السي تي سي.
ايوه انا فاهم. اوكي
اوكي.
اوكي اوكي اوكي.
جود
اوكي
لك يا باشا.
شكرا دكتور.
يلا بينا. اوكي يلا بينا عشان الناس بدأت تنام بقى وكله بقى لسه. احنا خلاص هنخلص اهو 5 minutes وهنخلص. حد يجاوب لنا على السؤال بقى ده. يلا بينا. دكتورة ريما، احنا بنقرا من كورس ده غلط. سي تي سي واقري جنبه اي حاجة تانية. ان شاء الله تقري ورق جرايد جنبه. سي تي سي واقري اي حاجة جنبه. اوكي. What do you think about JC therapeutic plan? Any modifications would you like to affect? ايه رأيكم؟ تعال نبص على جي سي كده therapeutic plan. Any modifications? Is it sufficient? Where is it? Yes, here it is. This is the therapeutic plan. What modification you may add here? David saying statins. Okay. Leah saying ACE inhibitors. Yes, correct. Statins and ACE inhibitors. Yes. Okay. We can add statins and we can add ACE inhibitors if we would like. With the patient's taking metoprolol, his blood pressure patient. Okay. No history, no problem in his heart or something. So I think we can go for ACE inhibitor instead of metoprolol, or even in combination to protect the kidney. And statins as well, yes, because he's above 40 years old and he's diabetic now. So he has to get statins. Okay, perfect. ACE inhibitors and statins are very important. Okay, my friends. What about the omeprazole dose? Is this sufficient? Should we increase it? We can increase the omeprazole dose. Yes. Okay, my friends. Here. Yes, insulin dose adjustment and titration. This chart is very important. Start with bedtime.
معلش، هو احنا ممكن نزوده ليه الأوميبرازول؟
تزوده عشان patient عنده history من الألسر، ياخد أدوية بتأثر على الجي اي تي. اوكي. فممكن تعمل duration، فلازم تزود الدوز ل 40. ال 20 دي مش يعني ما هي دي preventive مش protect. يعني هنا العيان عنده مشكلة، يعني ان هو عنده history already من الألسر.
الألسر، وكمان بياخد أدوية بتعمل ممكن تعمل له نوزيا وفوميت يعني.
Yes.
مم.
Yes.
مم.
Okay.
اوكي.
مع ال ACE inhibitor مع ال cholinesterase inhibitors they cause may cause ulcer أصلا. They may give risk to gastric ulcer as well.
Yes.
Okay. Perfect. Okay, we have some miscellaneous questions here. You can read it بقى وتجاوبوها مع نفسكم. لو حد ليه عنده أسئلة يقول لي. Okay, when to screen, when the metabolic decompensation, initiate and dose titration and insulin. Yes, difference between Baqsimi and glucagon. This is the only question that we will answer here. Do you know the difference between glucagon injection and Baqsimi? Have you ever heard about Baqsimi?
No.
It's a new medication in Canada. It's not new. It's been 2 or 3 years now in Canada. The Baqsimi.
ايه التقسيمي ده؟
Nasal. الله ينور يا دكتورة إيمان. It's nasal glucagon. Okay. Baqsimi is nasal glucagon. Glucagon is like the intramuscular injection, the IM glucagon, normal glucagon. Okay. Baqsimi is nasal. It contains 3 milligrams of glucagon. How many milligrams for the injection? It contains how many milligrams? How many milligrams for the injection?
5.
1.
One يا أرمي. 5 في عين العدو يا أرمي. 1 بس. It's only 1 milligram. Okay. For Baqsimi, it's 3 milligrams. It's the same concept like Narcan nasal spray. It contains only 1 dose. So it's usually recommended to give the patient 2 doses of Baqsimi. Okay. To try one. If it's not effective, he can give another one. Okay. Only 1 single dose. No priming needed. Spray it in 1 nostril and don't repeat the dose because it contains only 1 spray. Okay. Yes, for unconscious. Yes, for unconscious patient. Okay. If it's not responding within 5 to 10 minutes, give another dose, and you have to call the 911. Okay.
So, Dr. Both are for unconscious patients, right?
Yes, correct. It's glucagon. Yes, glucagon. That's why it's a spray.
وايه السسبنس في الشرطه دي؟
يا باشا
ده في سسبنس في شرطه وكلام كده.
مش عارف شرطة
دكتور
دي شرطة دي مش عارف.
استنى يا ديفيد. دكتور بالنسبه احنا بندي ماكسيموم 2 دوزز منه ولا ممكن؟
For the Baqsimi, for the glucagon, maximum 2 doses. For the Baqsimi, I think as well, maximum is 2 doses. I think. I'm not sure. But I think yes, you can give only 2 doses.
لكن هي يونيت دوز يعني زيها زي الناركان.
Yes,
هي يونيت دوز.
Narcan, the same thing. Yes.
فانا بدي
There is a video on YouTube. You can watch a video on YouTube. Baqsimi nasal spray. You will get all the.
انا بدي في 1 نوستريل واستنى من 5 to 10 minutes. لو مفيش استجابه ادي الثانيه.
Yes, so usually yes, up to 15 minutes, I think. Up to 15 minutes, you can wait and give another one if there is no response. Okay.
ماشي.
Any questions?
شكرين.
وصلنا بالسلامة. سيشن طويلة طبعا.
لا بس جميلة. ميرسي يا دكتور.
سيشن مليانة بس التوبيك غبي أوي بتاع الدايبيتس.
بس معلش أنا ليا حاجة. إحنا كان في محاضرة بكرة هناخدها ولا إحنا هنشفتها؟
والله I think